in gradually. Welcome. This is Quality Improvement Patient Safety Day. It kicks off Patient Safety Week here at Erlanger, and this is a celebration of our minds and hearts coming together, trying to not only improve patient care, but also improve care for one another. So healthcare is a lot of work, and it can get really tangled up. And so the reality of our partnerships, whether that be just physicians working together or physicians working with their nursing partners or their technical staff, our folks who help keep the place clean and orderly. All of these folks basically are necessary and essential to having good quality for not only our patients, but for all of us too. So I really celebrate that in my mind, and I'm grateful that everyone's here. I want to kick off today with an opportunity for our system leaders, Dean Haynes and Mr. Jim Coleman, just to give us some welcoming thoughts, and then we will move on to our program.
Good morning. Small group, but a good group. But just tell you a little bit about myself. When I first started it, I think most people heard when I started at Erlanger many years ago, I was a respiratory therapist and did that role through being the director of the department, sort of the Terry Ellis of the world now, and then switched over. We had a president and CEO then named Jim Pickle. And Jim Pickle came back from some conference, and this will sort of date me, but you'll get the picture. He came back from a conference where he'd heard about this new thing called CQI. What is that? Continuous quality improvement. So he asked me, I did a lot of those things in my department already. I was working on my master's at the time. And he said, would you like to be the first quality director at Erlanger? So I was the first Adam at Erlanger years ago, and really believe in the process of quality improvement, collaboration, interdisciplinary looks at different problems. And so this day that we focus on quality improvement and patient safety, and those go hand in hand, just want to congratulate you all and thank you for what you're doing. I'm going to probably leave after our introductions with Haynes, and I'm going to try to get back because I want to see some of the presentations from the projects. And just wanted you to know that as a leader of the hospital, I'm definitely committed to quality improvement, patient safety. When I came on board, I wanted Adam directly reporting to me, which he does, because it's very important to me that we keep in track. We've got a great leader, a great group of people working on these, and I'm looking forward to seeing the collaborations that you've had today focused on improving our system with the bottom line of improving patient safety. Thank you.
Thanks, Jim, and thanks to all who are here. I'm Dean Haynes, family doc by trade, and I really appreciate Adam and Jeff and our evaluators today for being here. So what I'm going to say in opening comments really are not anything novel, but an academic medical center must meet all the standards required of any hospital in this country. Additionally, our physicians and the hospital must meet standards by the Accreditation Council on GME to ensure medical training occurs in a setting where the quality of patient care is excellent. So there's something called CLEAR, or Clinical Learning Environment Review, that has 6 focus areas, which is patient safety, healthcare quality, teaming, which I'm glad we have interdisciplinary presentations today, supervision, well-being, and professionalism. And I'm going to leave you with a couple of quotes from Deming. A person and an organization must have goals, take actions to achieve those goals, gather evidence of achievement, study and reflect on those data, and from that take actions again. Thus, they are in a continuous feedback spiral towards continuous improvement. That is what Kaizen means. And if you've ever heard of Kaizen events, which I learned about a lot from Dr. Campbell and his compadres up at UT during my MBA. And then transformation is not automatic. It must be learned and it must be led. So obviously the folks that are presenting today are leading this along with Dr. Campbell and Dr. Bennett. And I want to leave you with this. The greatest waste is failure to use the abilities of people, to learn about their frustrations and about the contributions that they are eager to make. So obviously everyone had to step out a little bit to produce, have some ideas, gather some people together, and try to make a difference in a area within their sphere of influence and their sphere of work. So very thankful that folks took the opportunity to do that and looking forward to the morning. So Dr. Bennett. Thanks for the heads up on the board.
Yeah, we got a trip hazard up here. So safety first. I'm going to tuck it away a little bit. All right. Well, there you go. There you go. You point out a safety hazard and a frustration, and by golly, something can happen. Well, this morning, we thought we'd get started with a keynote address. This is the first time we've ever done this. And this was actually Dr. Campbell's idea. And we're trying to basically create a cohesive program that over time we can build out over multiple days. It'd be something that we really think this could be a regional meeting, a gathering that celebrates safety and quality. So this is a very, very early start, and y'all are part of it. So maybe 10 years from now, we'll look back at this moment together and say, golly, that was a humble beginning, but here we go. I'm going to welcome Dr. Eric McCart to the stage. He's one of our assistant professors over in internal medicine. Is that correct? And he also helps to lead his academic training program and is the quality leader for his department. And he's going to give us some thoughts on QI in healthcare education. So thank you, Eric.
This cord. This must, yeah, that is actually a very large cord. I would definitely fall off that. Good morning, everybody. It is earlier than I am often here, but I'm excited, and it hits a little bit different the day after an hour loss of time at night, which I didn't care about as much until I have kids, and now that seems to have an effect for the next 3 days afterwards. So thank you, Dr. Bennett, for introducing me. I am the Division Chief of Internal Medicine. I'm champion of our quality improvement there. And I just kind of wanted to, as the beta test for the keynote speaking, kind of go over quality improvement with medical education and kind of historically how we've gotten to where we are in medical education as it pertains to QI. I have no disclosures for those interested in it's the Office of Quality Assurance Manager. So the question I get a lot when the residents come to me and say, I want us to do a QI project, it's, well, this idea I have, is it QI? Well, is it QI? Is it research? I'm not sure. So the question really comes down to what is QI? And that's one of the more common questions we really get. It seems to be a pretty intuitive one when you try to sit down and answer it and write it down. It is challenging, but ultimately it's the framework that we use to systematically improve care, little by little, finding error and finding issues, and additionally reduce the variation. So when we have someone that comes in with COPD, we know how long they're going to stay here. We try to minimize the variation from the optimal. We think we can get them out of the hospital in X amount of days, trying to decrease the time when they have a 7-day admission. Wanting to make sure that we have predictable results, that we have that patient we expect, and it's going to be a similar duration of time and care and outcome here as it is at any other hospital in the area. Want to make sure that that ultimately improves the patient outcomes on a patient level, and that we improve that little by little to where we have a system and organization that improves with those small interval changes. QI shouldn't be complicated. I know we get real frustrated and it can be very complicated, but it should be easy. I have a problem. My COPD patients are staying in the hospital too long. They're not getting out fast enough, or that we have variability in how long they stay for each doc that we have in our group. All right, well, let's look at that. What's that problem? What goes into that problem? What are all the steps that go into taking care of that patient from the moment they come into the hospital to the moment they leave, the treatments, who sees them? What are the most common issues that keep them here longer than they should? What are those causes? Can we do a flow of how this patient has gone through the hospital and what inputs go in there? Because when you start to sit down and really think about it, you might think at the beginning, oh, I know exactly what I have to do. I just have to change this, that, or the other. But when you really realize all the different steps, there's a lot of areas in which you can think that's the problem. There's an area, there's an opportunity for change and improvement. And you get everyone together that manages that patient, because it's not just you potentially as the doctor, but the nurses are managing them at the bedside, do respiratory therapy, and all the people that have a stake in getting this patient out of the hospital safely and quickly. You can get them all together. And then you go, okay, well, how well are we actually doing? What is our data? Do we actually know how well we do with that? And you put all that together and you come up with an answer that you think might be able to move you a little bit closer to improving, small interval improvements. And that, in a nutshell, is quality improvement. You've just brainstormed half the PDSA cycle right there. And so what you've really just done is kind of answered these kind of the, for folks in internal medicine, the IHI, we use a lot and lean on that a lot as far as guiding how we manage QI, but just answering these questions. It's just, you're keep it simple, stupid. What are we trying to get accomplished? We want to decrease the COPD duration of length of stay. Well, how are we going to know if that change is an improvement? How do we know if we've made anything actually better, if we do any change? And how do we know if that change actually makes anything better? And so just kind of brainstorming, all of a sudden, this model can be applied to anything. And actually it has been applied to most things, because QI isn't something that we did not invent. We kind of stole and retrofitted for our own purposes. This is something we've taken out of manufacturing, we've taken out of other industries who have made leaps and strides, and we've just kind of piggybacked on it and reverse engineered it for ourselves. And it's an interesting kind of course of where we've come from and how we've gotten to where we are, where QI is pretty well integrated into every aspect of the products we get, what goes into anything you bought off Amazon, or the streamlining of all the processes that we interact with on a daily basis, or we receive the benefit of it with the products that we purchased or have used. So just even from the beginning, if you will humor me from a history standpoint, QI didn't really exist as much of anything up until the 19th century. Before, it was basically just a craftsman. You got a guy in your town, they make the swords. He learned it from a guy that taught him. And there wasn't really anyone checking in on his quality of how he managed it. It was basically the end product. Was that sword good? Did it cut? Did it do what it wanted to do? If it did, excellent. If it didn't, toss it out. We'll do another one and we'll tweak it. And so on and so forth. And it didn't really come until you got your industrial revolution, where you have everyone centered into a factory evaluating products created. And now you have audits, you have inspections. But what they weren't really looking at was how they got made. It was really just the end product. Was that a good end product? Was it a bad end product? Was it defected? All right, well, let's scrap it. If it was bad, let's rework it. If it was okay, but we just need a few tweaks. Same thing happened in America, except we tweaked it a little bit. We had specialized engineers, we brought in supervisors, but the goal wasn't to increase the process. It was really just looking at, can we get the most productivity out of this without having to pay anyone else? No more skilled labor than needed. So we got a lot of productivity out of it, but the quality didn't improve with that change. And so, as is with lots of things, war by necessity often is a mover of innovation by necessity. And so you have World War II, and all of a sudden all this productivity and this industrial revolution gets focused towards military production. And now the quality now is of national importance, of life and death in regards to what they're making. And so now all of a sudden you have introduction of sampling inspection, this establishment of some product standardization and sampling tables. And now you start hearing this term, the process. And for the two that might get this reference, if we're not talking about Nick Saban's The Process for his football team, this is the process of what happens going from the initiation of what goes into the creation, kind of that black box of products, base goods in, the process of creating something, and then what comes out of that goal of what you're trying to create. And now all of a sudden we're starting to look more closely, not just at was the final product good or bad. Well, each step of this process, we can now look at it and say, we can tweak this small aspect of the process that ends up making that end product better or more timely or more efficient or cost saving. And you can turn that process and evaluate it to get data. And data can be analyzed, it can be controlled, it can be improved. So now all of a sudden you have this process, the idea of evaluating that and tweaking that improvement. And now you're starting to see what starts to resemble quality improvement in today's time. After the war, we kind of tailed off a little bit and didn't transition all those gains that we made with military quality production. But the Japanese did and created what's kind of looked at as total quality, because before they were kind of viewed as they had inferior products, shoddy design, and their products worldwide did not have any recognition for quality. And so they set to use all those tools that were created and focused on their manufacturing, and started to create this kind of the standard for quality in the industry, to where now they're regarded with their products as having some of the highest quality and least variation with what they create. You have Toyota with their entire Toyota production system and what they evaluate, and basically evaluating every aspect, minutia of their quality and their process of creation. and basically kind of pull a Maria Kondo and grab everything and look at it and say, does this bring me joy? Does this add value? Is this something that we need? And if it doesn't, if it's waste, then we toss it. And minimizing any waste in any aspect of what they do, from inventory, weighting, motion, movement, transportation, overproduction, inventory. So every aspect of what they do, they evaluate constantly, which is that's QI. It's continuous evaluation, continuous evaluation for opportunities for improvement. And so now we have quality management systems in every industry: manufacturing, aerospace, airlines, and with us, with healthcare. In quality in healthcare, we've kind of had similar leaps with military. One interesting example you found was all of a sudden you noticed the British noticed in 1854, a lot of our patients, a lot of our folks they're not dying from the war itself, they're dying from cholera and diarrhea. And they got Florence Nightingale to come and evaluate what was going on. And she made small interval changes. And I'm sure she got a lot of pushback with the generals thinking, why are you worried so much about how far the beds are apart? She's moving the beds 3 feet apart. She improves ventilation. She decides, you know what, it may not be a very good idea to house our horses right next to our hospital and just leave them there. Maybe that's affecting our water sanitation. Maybe we should evaluate our sewer. And so these things that seemingly don't have anything to do with the war effort, all of a sudden in 6 months, she's dropped mortality in these hospitals from 42% to 2%, significantly improving the war effort. In the American Civil War, the Union forces found that for every man that died from a bullet or a sword, 2 died from dysentery, typhoid, and malaria. And they created the Sanitary Commission, piggybacking off what Florence Nightingale did, and inspected hospitals, kitchen sanitation, and did blanket raids where they check for the sleeping arrangements and evaluate for hypothermia in their soldiers, and had a significant, and is noted as a significant boost to the Union efforts for their war efforts. And so on a macro level in our healthcare system, you can kind of see where we have kind of an overall governing body look and evaluate at our state of our healthcare and our hospitals in the 1950s and realize that our hospitals aren't performing at the same level. There's a vast discrepancy in how some hospitals perform versus others. And so they created a joint commission to evaluate and try to set some level of a minimal standard for these hospitals so that the hospital quality was some semblance of similarity between one hospital and the next. In 65, you get Medicare and Medicaid, and now you have a vested interest to make sure that the quality we're providing is similar, and to try to evaluate what the data around the patient care that's being received. And you have multiple iterations after that: utilization review committees, then experimental medical care review organizations, and finally the peer review organizations, to evaluate and try to come up with a way to evaluate quality and to look at it in a way that you can translate what's happening in hospital A to hospital B. You have the introduction of DRGs and evaluating, trying to say, well, the COPD patient in hospital A is leaving in 7 days. COPD patient in hospital B is leaving in 3 days. Why is there a difference? Are those 2 patients the same? Can we quantify how sick patient in hospital A is versus patient B? And before that, it's very challenging if you don't quantify some level of turning how sick the patient is, staring at them at bedside. I can see that, I know how sick they are, but to put it on paper and to be able to quantify it and compare it are 2 different things. And so that's what they set out to do, because ultimately with QI, if you do not measure it, if you not evaluate it, it's very difficult to compare and understand how you're doing compared to your peers and ultimately learn and improve. And this kind of brought us to this point where before we hadn't really been on anyone's radar in healthcare for quality improvement until about 2000, when the Institute of Medicine puts out "To Err is Human," and makes this controversial but very provocative statement that almost 100,000, potentially almost 100,000 people die every year from medical errors in hospitals in our healthcare system, which really woke up a lot of people to this. Because if quality is not met in civil engineering, a bridge collapses and it makes national news, everybody knows about it. And there's inquiries and we evaluate and review and there's interventions made. If an airline doesn't do good and it doesn't perform their quality checks and an airplane crashes, it's major news and everyone evaluates it, and we do some introspection. If one patient stays a few days longer or has a bad outcome, there's not national news. There's not an inquiry at times in this setting, and everyone goes about their business. And this time, the assumption is, well, doctors are, they don't make mistakes. Nurses don't make mistakes. They're all doing their best and they're all taking care of the patients, and everyone's getting as good care as they could. I've seen Grey's Anatomy. They come in, they get a code, they're fine, everybody's great, and they leave at the end. So this kind of really took the blanket off everyone, kind of exposed the situation to what it was, that there are true errors that are occurring in our system, and we need to take a closer look at it from a quality standpoint. And a lot of these errors, almost in the industry, they like to kind of quote that most of them, 60 to 80% of errors are human errors. They're not technical errors. They're not a failure of a device. They're human errors of some level. And the big thing they wanted to focus on was these are not bad doctors. These are not bad nurses. They're good doctors or good nurses in a bad system. And it's a system that is setting up physicians and nurses and staff to not have the outcomes desired that they might otherwise be able to in better circumstances, because these errors, they don't occur in a vacuum. You're not taking care of your patients the same way on hour 1 as you are on hour 36. You're not taking care of your patient the same when you have 3 patients as you are 30 patients. So there are system issues that can be evaluated to understand how they affect our ability to care for our patients. One thing I thought was interesting is they evaluated errors and kind of put them into 3 categories: slip, a lapse, or a mistake. Where the first two are, I wasn't able to, the intention that I had was not with the action that was conducted. So for a slip, I have my patient with UTI and I ordered the ceftriaxone, but I did it at the wrong dose. I gave them 20 grams instead of 2 grams, or 10 grams instead of 1 gram. A lapse would be, I know that the patient has a UTI and I wanted to order the ceftriaxone, but I was so busy, I forgot to order the ceftriaxone. And then a mistake is, I ordered albuterol for her UTI. My plan got executed exactly as I wanted to, but that was not a good plan, or there was an error in the plan itself. And since the Institute of Medicine put out to Err is Human, we've had a lot of focus on QI and a lot of focus on what changes have been implemented since then to try to make sure that we're giving quality improvement the focus that it needs. And so we have an increased focus on it. We have an increased improved reporting of safety events, hoping everyone in here has either been a part of or has seen e-safes been put in. If not, meet me afterwards. I can show you how to do those. But they're vital to understanding where these errors occur, because if we don't see them, don't know about them on a system level, we can't fix them. We've also done great to shield the hospital reporting from legal discovery of these e-safes so that we can try to help support and encourage a culture of safety and safety for reporting. So it's not a punitive thing to put those in. It's an opportunity to learn for the system on what's going on. And my legal advice for the day is that they are not available for legal discovery unless you document in the chart that an e-safe or a RCA is being performed. That was my legal told me about that. And so that is something I've stored away for the future. So do not document in the chart, because then it is now legally discoverable. RCAs, we do a significant now more as far as root cause analysis on those e-safes that rise to the level of error and harm, to look at and as opportunities to really dive deeper into these issues so that we can understand how they happen to prevent the next one. You have an increased emphasis on protocols and bundles. So we know with errors, if most of them are human errors, how can we limit human errors or decrease the variation in what everybody's getting? So in the ICU, you have your bundles. Everybody comes in, you've got a bundle set. So everybody's going to be checked for, do they need DVD prophylaxis? Do they need a PPI? Do they need stress ulcer prophylaxis? All these bundles to make sure that the care is similar with as minimal variation across the board. And these bundles and protocols, so stroke protocols when they come in, are implemented to try to offset that and try to minimize variation so that the care provided by Doc A is similar to Doc B, and hopefully optimized in that manner as well. And similarly, focusing on evidence-based care and emphasizing the importance of that, so that when you have a patient with pneumonia, the care that I give this patient is evidence-based. The care that Dr. B gives is evidence-based, so that variation is minimized and we're optimizing their care. And then trying to set reporting standards and patient care standards across the board. Again, trying to just minimize error and minimize opportunity for variation. And so from a quality and improvement standpoint in the medical education, ACGME has taken this very seriously, and there's entire 2 pages of the ACGME guidebook devoted specifically to quality improvement and patient safety. And now there's long and arduous, and I'm not going to make you read all of these, But just to give you an understanding of what they are, they have a huge 2-page list of all the things that they expect out of a program in resident education by the time you're done to understand quality improvement, with the goal of, at the end, having a good understanding of the tool sets of it and to continue to contribute to culture of society, even when you're done with residency, and be able to understand how to do that. So they give you the tools to do that. They want to make sure that you've promoted educational activities around patient safety techniques. They want to make sure that you know how to report a safety event. So again, making sure that you understand how e-safes work, putting them in, they're not punitive. Understand, even if it's a near miss or not, it doesn't have to just be that a patient received harm, that it had to be an error. If it is an almost error, it's a near miss, those need to be reported too, so that the next one doesn't become an actual safety event. And then making sure that you participate in some level of root cause analysis of these near misses or these safety events as a core part of what we want out of residency education in regard to QI. And then to make sure, and this is one that's challenging, make sure that you understand and have training on how to disclose these adverse events. Because if an error occurs, an event occurs, we have an obligation to the patient to tell them that that has occurred. And this is challenging and tough, but it's important. I mean, from a less important standpoint, it decreases your chance to get sued. But on a more important standpoint, it's what the patient deserves. It is the correct and right thing to do, but they're not easy. The statute of limitations has passed on this, so I can say this, but and this dates me a little bit, back when we had the paper charts and you would write your order and you got to fold the paper over and put it in a little tab to tell them what the orders were. We had a patient that needed an IVC filter. I ordered the IVC filter and talked with vascular afterwards, and they told me that patient in no way needs an IVC filter. And I went and canceled that order, but that cancel order was not received by interventional radiology, and that patient received a procedure they didn't need. No harm occurred to that patient, but a procedure was underwent that the patient ultimately was deemed not to have needed. And I had to go into the bedside and talk to this patient and lay out that what had happened, that I was obviously, best intention to treat this patient as well as I could, but an error occurred in what was I wanted to happen for that patient versus what they actually received. They were not happy. They were upset. But ultimately, they were very appreciative that I was straightforward and upfront with them and let them know what had occurred. And these are challenging conversations to have and to be part of that. But I think it was a good learning opportunity for me and everyone involved with it as we sat down with a root cause analysis of how this error could have occurred when the order was canceled, but the procedure went on as initially intended. But these are important things because everyone makes mistakes and everyone will have an error at some point or be involved with an error during your career. And you need to make sure you understand how to navigate that because it is challenging. We want to make sure these residents are getting quality data, understanding what their patients' quality care is they're receiving, as well as making sure that they're understanding they're participating like we are right now in quality improvement activities. You are satisfying ACGME requirements as we speak. So congratulations. And then finally, doing those activities also aiming at healthcare disparities because we know that care outcomes are different across landscapes and are different across our patient population, particularly in our communities of color. They're getting different care at different levels for different reasons, which is a completely different topic, but an interesting and a needed one. And using these opportunities, these QI opportunities to address those is something ACGME, CLEAR, we're trying to improve and emphasize in what we do. The current state of QI education kind of falls in 3 categories. And we're really still information still up in the air as far as how effective these are. Everyone's getting mostly formal curriculum. You have IHI modules, you go through that, you learn about all the tool sets, your knowledge expands on what QI is and everything, but data doesn't really show out that helps you become a better lifelong learner in regards to QI. It doesn't really show to say, well, if I go through these modules, when I go and practice on my own, I will institute QI in my everyday practice. Another aspect of it is to give our residents, I mentioned specific skill sets that are proven out through QI that work and improve quality of our patients and patient safety. So adequate patient handover, you've got their pass the torch or SBAR, all these tool sets, or making sure you're hand washing in and out of each room, or ICU checklists and bundles help in isolated, siloed situations, but aren't really expandable out to a skill set that can be used in the future beyond those small situations. And the last one is really the ones that we want to focus on and try to get more involvement with is what we're doing right now. These real life quality improvement initiatives to where you are involved actively and passively in a project with the intent that you are using these tools actively and working through from a problem to a solution or an intervention and seeing the outcome of those and using these real life quality initiatives to get those tools, use them and feel comfortable with them so that in the future, ultimately you can be part of a safety culture in what our ultimate goal of all of this is. And so leading into kind of what our goals are for even introducing QI and having it as part of what our medical education is, it's to ultimately integrate QI into every aspect of our patient care. So it shouldn't be a competing demand with your other work. It shouldn't be you're on wards and I also have to do my QI project. It should be I'm on wards and what opportunities for learning in QI are there within the patients that I'm seeing every single day in my clinic or on the wards. We want to increase the number of eSafe entries. A complaint I commonly get is, well, if I don't eSafe, it doesn't matter. Nothing changes. If I don't put them in, I just don't want to put them in. I don't want to just badmouth this nurse or this doctor. If we don't know about it, we can't change it. So if we don't know where these errors and these delays or inconsistencies are, we can't fix them. And so we need that information. And we need to make sure that we're promoting residents to actually participate in these root cause analysis. So when an eSafe is put in and it rises to the level of an error, and we can look at where in the system these errors are occurring, be involved with that. Follow up on the eSafe, follow up and be part of the solution when you have this problem so that that eSafe can actually make a change. It's a big push with AMA, Society of Hospital Medicine, trying to push for more involvement with that, as well as, you know, when you guys have gone through your quality improvement projects, how many times have you gone to your faculty and said, hey, I need help with this QI, and the faculty kind of go, I'm not really sure I know all the QI tools I can help you with. How are we supposed to train you guys if we're not as comfortable with it as we'd like to be? So kind of train the trainers. We need to be very comfortable with it from a faculty development standpoint so that we can guide you guys adequately on how to use these tools and do this from the top down with it. We can't just be Dr. Bennett and Dr. Campbell giving everybody help with our QI projects because there's only 2 of them. So we need to improve the trainers as well. And then try to just move again, this continuous theme of trying to become a lifelong learning tool as opposed to a project to checkbox. I need to graduate with this. I need it. My checkbox done. I'm good. I'll see you later. And so ultimately trying to, you know, it's corny. We talk so much about being lifelong learners, about cultivating intellectual curiosity and having that be just a mainstay of who you are as a physician and clinician, and not so much just you never really just arrive at I know everything. We never just arrive at this hospital is QI and PS, you know, patient safety approved and we're done. There should be a continuous lifelong approach to this and integrate it into everything we do to create this ultimate culture of safety. And that should be the goal that we're continuously working to. This phrase, it gets attributed to multiple people, but ultimately I have to kind of read it several times to feel comfortable with it. Every system is perfectly designed to get the result it gets. Seems kind of redundant, but ultimately it kind of lays out that our system's going to get the results it gets. That's what it's. This is our design and this is going to be our outcome. And until that system changes, that outcome will not change. And we cannot expect it to unless we can change that system. And I think ultimately that's what it breaks down to. It just says it in a way that turns my head a few times if I look at it too hard. With that being said, I want to thank you all for having me. I thank you all for letting me talk with you, and I'm excited to hear about everybody's projects and watch how everybody's products have unfolded, and to continue to encourage you all to incorporate QI into what you do. So thank you guys.
We're about 15 minutes ahead of schedule already, so that's pretty cool. If anybody wants to take a minute and get some coffee or whatever, grab a little whatever's out there to munch on. We're going to take a few minutes and start getting things teed up, and that way, if you guys need to catch up on some texts or emails or whatever, you're welcome to do that. I know that this is plopped down in the midst of a lot of other activities, And so take, like I say, take about 10 minutes and go ahead and work on those things. And we'll reconvene here and get the ball rolling. The reason I'm doing this is because I think our different team members kind of know when they're going to be speaking, and they may be rolling in kind of around those presentation times. I don't want to have anybody feel like they're being left out or pushed around. So that's the motivation behind that. As Eric said, you need to start with a why, and there's my why. So everybody take 10 and we'll get together. I guess the centerpiece of this morning's proceedings, which will be our selected platform presentations. I do want to take a minute real quick to thank you, Dean Haynes, for nudging me in this proper direction. I want to introduce Tammy Elliott, who I'm sure you guys have heard from again and again and again and again and again. She has done an amazing job of communicating and over communicating and pulling all of our random thoughts together to some cohesive structure. And without Tammy's incredible work, none of this would have been pulled off. So let's take a quick minute and give her a round of applause. Okay, I'm gonna next introduce, Dr. Adam Campbell. You all know him as well. He's all over the enterprise, teaching, coaching, and explaining how all of our quality systems interface with our clinical systems. And so he's going to take a quick minute, give some follow-up thoughts to Dr. McCart's morning presentation, as well as introduce our judges and the rubric that they will be utilizing for our juried panel today. Thank you.
All right. Thank you, Tammy.
Thank
And
you.
thank you, Dr. Bennett. It's a pleasure to be here and have everybody with us this morning. I want to thank Mr. Coleman and Dean Haynes for kicking us off this morning with some wise words, which is always good to have good senior leadership support for this as well. And I want to thank Dr. Bennett for all his work to help us put this together as well. We're in the process of seeing some very good presentations today. There will be an award for best presentation. And we'll have some judges here, which I'll announce in a moment. But first, I'd like to follow up on a couple of things that Dr. McCart really said. First, as Vice President of Patient Safety and Quality on the hospital side, we do a lot of investigation into safety events through eSafe. We have a whole team that every day looks through every eSafe that comes into the system. It's a lot of work, but that is followed up by root cause analyses, like Dr. McCart stated. We use what's called HPI methodology. It's a very standardized way in which we do those root cause analyses. We follow very standard processes and how we code different levels of safety events. So when you put eSafes in, we highly encourage it. Even those near misses, even things didn't reach the patient, but something didn't go exactly to plan, put those in. Those are learning opportunities. We follow what's called the Frankel model as well for MyHI, where we really are building a culture and becoming a learning system. So eSafe on the patient safety side is really the main way in which we find out about those areas of opportunity for improvement. The second thing is, Dr. McCart mentioned way back in 1951, Joint Commission started dipping its toe in the water on accreditation, where there was minimum safety and quality requirements for hospitals. There are other accrediting bodies now in the industry, one of which is DNV, which we partner with for our accreditation of the hospital system as a whole. Part of becoming accredited by DNV is you become certified in what's known as ISO 9001. And ISO 9001 is a set of criteria, sort of that next level. Another thing that really came out of manufacturing, and it's really criteria around how we set up a quality management system, how we communicate about quality, how we identify opportunities, how we have standard quality improvement methodologies. So amazingly enough, your accrediting body and how you partner with them also allows you to take your quality and safety programs to the next level. So as we hear Dr. McCart tell us about the history of how this comes to be, Erlanger UT, we're partnering to take this to the next level, both through our accrediting partners and through ACGME. Okay, it's very important how we harness that and use it to our benefit. So thank you, Dr. McCart, for some good pointers this morning on quality improvement. And if you would like to go through a quality improvement workshop, and I want to thank Dr. McCart, we're beta testing this with the interns in internal medicine. Please reach out to me. We have a very short QI tools and methodology workshop and coaching program where we can work through project with your teams so we can further exemplify some of the things we'll be seeing today. So with that being said, I'd like to introduce our esteemed judges for today. They will be following a rubric, as Dr. Bennett said. We'll be scoring the presentations. Don't be nervous about any of this. We'll just be kind of hanging out in the background and taking some notes. And after everybody presents, we'll be deliberating and we'll be picking the best presentation from the ones you see on the screen today. There will be a focus on the use of data, the use of QI methodologies, of course, and outcomes, the idea and the outcomes. So we have categories that you can attain points through to get up to a maximum of 35 points. So we'll be going through that process and deliberating at the end. And we'll be coming back here later in the morning to announce that winner. So that'll be great. So our judges today, first, Senior Director of Clinical Education, Jill Steelman, is with us today. She was a judge last year as well, so she's a repeat offender. So thank you, Jill, for being a judge this year as well. We also have Greg Garrett with us, who is the Director of Organizational Development. So thank you, Greg, for participating today and being a good judge for us. And Melissa Ellis, Imaging Quality Program Director, is with us as well today. So we really appreciate their time and being with us this morning to really evaluate the presentations. So with that, I'll hand it over to Dr. Bennett and we'll announce our first presentation for this morning, maybe with a little break in there a little bit, but I think we're on schedule if we have the first presenter up, and we'll get her going.
Thank you, sir. I think one of the problems with trying to figure out how things are going to flow is you worry that things will go too slow. And then you get in a situation where things are going a little faster than you thought, and you find out that's actually a little more uncomfortable. It's almost better if things are going a little behind and you've got to try and speed up to catch up. But I appreciate y'all, your forbearance. And I will take a couple of minutes just to add some thoughts as well. The nature of this morning and the nature of all of the work that's being done in support of CLEAR and ACGME quality improvement patient safety goals is centered in probably the deepest why that we have. And if y'all take a moment, just reflect on what you wrote to your College of Medicine or Osteopathic Medicine College application. What sorts of things did you write down? What do you recall from that? What were you chasing? What were you interested in? What did you believe you could be part of? And that probably is still deeply inside of all of us, but it sometimes gets a little lost in the midst of so much work, so much, sometimes confusing work, and the pressure to get a lot of stuff done. So I think at the heart of what we're doing is we're trying to reflect on the things that brought us together as nurses and physicians and other care partners, and to center ourselves in the abilities to provide care, the care we envisioned, reliably and with confidence, and hopefully with some joy. As you reflect on some of those things that you may have written down in those applications, it may hurt a little, because I've done that. I've looked at it and I felt a little bit of pain. I felt a little bit of distress. And it's actually quite interesting when you reflect on those things that were so motivating to you at one point in time, and you question whether that motivation is still inside or what's actually now motivating us. I think that those reflections are empowering. And a big part of today is thinking about and celebrating our shared motivation to do good with and by each other and face those difficult challenges, whether they're from outside of our organization, from the other systems that influence what we do and all their expectations, or within our system and each other. And to try to, again, find the things that center us, the things that patients need, and the things we need in order to provide that. So today is really, I think, an opportunity for us to see how teams have come together with some of those ideas in mind, how they came to understand the situation that was behind a problem that they had identified, and how they walked closer to their goals through new ideas, trying things out, cementing the things that seem to work, and then moving on to the next step. And as Eric said, it's not as hard as we sometimes make it out to be. It's really important to understand that what we're trying to accomplish here is not research. We're trying to close a gap between where we are and where we believe we should be, and to use the tools at hand, most important of which is our own capacity to learn. And through partnerships, that capacity is limitless. So I'm so eager today to listen to our presenters and to support them. And I'm grateful that you all are here to do that with us. And I want to remind you that after we're done with the presentations here, we'll have a fairly significant poster session up in the medical mall. So another opportunity for us to walk through and celebrate each other's work and learn from one another. So without any further ado, I'm going to introduce our very first platform speakers today. Real quick housekeeping. Each speaker has 12 minutes for their presentation, and then there will be a 5-minute Q&A session to follow. So I'm going to try and signal you when you have 2 minutes left, so you get a sense of time. But maybe you'll have a little bit of a timekeeping device here up on the podium as well to make sure you stay within those bounds. We do that to level the playing field, make sure that everyone has a similar opportunity. That 5 minutes of Q&A certainly can center on judges in terms of things that they want to query about, but it's open to the room. So please utilize that time to draw more out of the speakers. They may find themselves in a rush from time to time, and you'll give them an opportunity to go back and grab a key point from their slide deck. So it's kind of a cheat. So it's a nice opportunity to make sure that we get everything out of every speaker. All right, so our first speakers coming from the Department of Family Medicine, we have Taylor Millirons and Hannah West, and they'll be sharing their project, utilization of IRIS to improve diabetic retinopathy screening.
Hi, I'm Hannah, like he said.
I'm
and-
Taylor.
And we're going to talk to you about the utilization of IRIS technology to improve diabetic retinopathy screening. There we go.
So the main problem, the background, diabetic retinopathy is a leading cause of blindness in American adults. An estimated 4.1 million or 899,000 Americans are affected by retinopathy and vision-threatening retinopathy, respectively. Nationwide estimate of 50% of patients at risk for retinopathy do not get their regular screenings to prevent this disease. And the ADA, the American Diabetes Association, recommends annual screening for diabetic retinopathy in patients with diabetes.
I advanced the slide.
There should be a place to advance it down. Let's see. Should be down here somewhere. Yeah, I'm
I
looking.
tried the down arrow
Yeah.
first.
This is why we had so much extra time into this system.
I don't see where you advance it, so I might need, where do you normally see it?
I do not know.
I can't remember.
Hey, John, are you around?
No, John's not here.
Oh, okay. That
Did it work?
advanced it. Yeah.
Okay, good.
Just said use that arrow right there.
Thank you.
Don't worry, that didn't come get you doctor yet.
So the current situation leading to this quality improvement project were Medicare benchmark goals for diabetic eye exam screenings being at a minimum in the 30th percentile, 80.7%, and in the maximum 70th percentile, 98.6%. So our project started with looking at the screening data from 2021 for diabetic eye screening exams at our clinic at UTFP, where we identified a range of 24 to 31% of screenings completed in that year. And then Erlanger Primary Care as a whole at 17 to 20% of screenings completed. Oh my goodness, it's not working again. Oh, yeah.
There it goes. It's just, our primary outcome is to increase percent of diabetic patient population receiving the retinopathy screening in the with Medicare recommendation of 80.7%. A secondary aim was to identify a nurse-driven protocol to select patients and screen them on their actual day of visit.
Some causes that led to this problem were a lack of ophthalmology availability, socioeconomic barriers to care, such as transportation, additional copays, and time off work for the patients, as well as a lack of buy-in for the importance of screening for diabetic retinopathy, and in addition, a lag time to obtain outside medical records of completed diabetic eye exams.
So our measures, so the process measures include monthly calculations of the percentile achieved with the use of a numerator and denominator of patients due for eye exams and those performed that month. So at Erlanger Primary Care as a whole, increased from 22 to 24% from the 17 to 20% by the end of 2022. And at UTFP specifically increased to 52 to 56% from the 24 to 31% by the end of 2022. Balanced measures to identify problems induced elsewhere in the system include relying on feedback from clinical staff as well as patients themselves.
So our PDSA cycles, cycle number 1, we plan to provide IRIS equipment to Erlanger Primary Care clinics to introduce diabetic eye exam screening, to improve our diabetic screening eye exam screening metrics by the end of 2022. And we did that by offering screening to patients during the visit, mailing out a records release form for the diabetic eye exams. And then we saw that there was only a minimal increase in screenings completed, so we needed to develop a different protocol for engaging patients. So cycle number 2, to improve our screening rates during our office visits was the goal. And then we did that by incorporating a nursing-driven system whereby nursing staff identified patients needing the diabetic eye exam during the rooming process, and then would perform an iris exam while the patient was still in the office. We looked at the rates of screening after we incorporated that cycle and decided that it improved our rates. And so we implemented that protocol as the standard method for obtaining iris scans in the office.
So here's a graphical representation of the data. So you can see in 2021, UTFP was slightly above the overall, but still well below goal. Moving into 2022, as we started to implement IRIS, you can see there's a significant increase from UTFP. And there were several other clinics in the area that also had IRIS, and then that, as a result, increased the overall IRIS or diabetic retinopathy screenings overall, but still less than the Medicare, Medicaid metric.
So the utility of IRIS technology led to an increased rate of diabetic eye exam screenings. We saw that there was a consistent improvement by using the nurse-driven protocols, and a majority of patients agreed to the screening when they were made readily available and did not require dilation. And then consistent feedback on improvement of the protocols led to our successful outcomes.
So some barriers and lessons learned, importance of optimizing patients and staff flow to improve patient outcomes and quality metrics, utility of nurse-driven protocols, so having more of a team approach, and setting aside dedicated training time for staff that's outside of their normal work hours, so they can be trained appropriately. And then participant buy-in for quality improvement projects is key to a successful outcome.
So some next steps for this project, continuing to train nursing staff and new residents on the awareness of the need to improve our diabetic eye exam screening rates, because we're still not at Medicare quality metric goals. And then expanding this protocol to other Erlanger primary care clinics to improve quality metrics there as well. So a possible PDSA cycle number 3 is implementing an additional step in the rooming process through Epic, whereas you have like a yes or no tab where the nurse goes through and says, has the patient had their diabetic eye exam screening this year? You can click yes or no, and then maybe order the IRIS exam screening so it's there in the system. So hopefully that would provide some consistency in identifying the need for patients with needing a diabetic eye exam.
And just references and thank yous. So I'd like to thank the Practice Care Quality Scorecard that's produced by the Erlanger Metrics team for compiling all this data and having it available to use, as well as UTFP faculty and staff. It wouldn't be possible without them. And then our main reference is the American Diabetes Association website.
And the most important slide.
So, questions?
My dogs are the dachshunds and Taylor has the farm. Do you guys have any questions? Yeah.
What are more specifics around the nursing protocols that were used to increase the rates of the tests?
So the way it works currently is there's an MA and LPN in our office that are kind of the main drivers of looking through the patients that are coming in today and kind of scanning. You have a diabetic code. Do you have an iris scan done within the past year? Thankfully, in the care gaps, that is helpful because that is already kind of earmarked, but you've kind of got to hunt for it at this time. And then the patients are asked in their rooming process if they would like to have that scan completed. They kind of give a quick little snippet of what that's like. And essentially all it is, you put on some big sunglasses, you hang out during your visit, and then after your visit, you go and get your eyes scanned in a dark room. So by the time we're actually seeing the patient, most of the times they're already wearing their sunglasses. They're just wearing that for the extent of their visit. And then on their way out, they get the scan done and they go on home. So it's a pretty seamless process, except like Dr. King was mentioning, Dr. West, sorry, was mentioning, there is kind of on the front end, there's some difficulty that's still kind of a barrier where those two individuals are still having to go through and manually look for all those patients. So as discussed, if there is a way to identify those in the pop-up when you're already checking your PHQ-9, your smoking, and then have you had your screen and do you want it? That way it's done already kind of for you as just your regular process. So.
Any other questions? Oh no, Gober, here we go.
Thank you for the presentation. I have to say, I'm very impressed with your data and the family medicine clinic for doubling the rates compared to their counterparts. Really impressive to find one single intervention making that big of a difference. So that's really incredible. What do you mentioned that there were some other clinics in your comparator data subset that also had access to these iris exams. What do you think set you and your interventions apart from these other clinics? Why did we not see their rates increase as much as yours?
Easily, the answer to that question is setting aside dedicated time for our staff to train on the equipment. Because a lot of the clinics have the equipment, but their staff isn't confident in the process and how to implement it. So this is really what that quality project, the heart of it is the nursing part, where you have set aside dedicated time for the staff to learn how to use the equipment so we can implement it seamlessly. Good question. Thanks.
And when you say nursing, that includes the medical assistant?
Yes.
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 Staff.
So with increased screenings, have you all had new diagnoses, new findings that helped patients get the care they needed? What were some of the stories from you?
I personally have or found patients that you ask them during like review of systems, do you have any visual disturbances, any changes? I'm like, oh no, it's always been the same. But then I've gotten at least one or two back where it was, no, you actually have some severe diabetic retinopathy. You need to be seen by an ophthalmologist. And so what this does kind of help is what we mentioned with patient buy-in is you have patients like, you need to get screened because you need to get your eyes checked. But when you are actually able to have the iris images and say, hey, you're at high risk, we're finding some pathology, you got to go see the ophthalmologist. You get an ophthalmology report in the next month or two where they've actually gone and seen the ophthalmologist, they're on treatment.
Well, thank you guys.
Thank you.
While Tammy does the technical wizardry behind the scenes here and gets the next one teed up, I will introduce our next speaker. And I'm hoping that the fact that we're moving a little bit fast, Dr. Court's in the room. Hello, sir. I'm pointing out Dr. Court because he ran this for 8 years and 8 or 9 and passed the baton a couple years back. And I'm really glad to see you here, sir. Thank you so much for joining us. And Dr. Pizzorno, good to see you as well, our Dean for Research. Thank you very much for being here. Our next platform speaker is representing internal medicine. We have 2 representatives for this project, Adam Volberg and Gracelyn Bowes, and they are presenting on Code Blue, a quality improvement student looking at the effectiveness of key interventions. So come on up and thank you.
Sorry, I don't know. My title got jumbled there on the first one. This is the real title. Good morning.
Whatever.
That's all right. That's not your fault. So my name's Adam Volberg. I'm an internal medicine PGY2. Gracelyn Bowes is also working on this with me. She's a PGY1. She's unable to make it today. She's on a stretch of nights right now, so I'll be flying solo today. But this is looking at ACLS guideline adherence at Erlanger Hospital. So super excited to share this with you guys. There we go. Just some statistics to share with y'all. So kind of why is ACLS guidelines, like why are they important? Well, cardiac arrest, it affects almost 300,000 patients in hospital per year. And, you know, if you look at the percentage of people that survive, 12 to 22% is not great. So there's not really a lot of margin for error there, making, you know, ACLS guidelines really important to follow. So that's kind of why we decided to go through with this. So our original question is kind of, you know, are we following ACLS guidelines and, you know, what percentage of the time? And, you know, with that question, we were able to find Get With the Guidelines. Is anyone familiar with Get With Guidelines? So it's a school quality improvement project the AHA puts on, and they also have one for stroke. So they had the similar question as we did, and they broke it down into kind of 4 different interventions. And essentially, what we're looking at is wanting to get 85% or greater with these 4 interventions. And so we're like, great, this has the same question. These are, interventions that we want to look at. And it gives us a chance to improve our outcomes, with cardiac arrest, and also, maybe win an award for the hospital. So all good reasons to kind of pursue this project. So spoiler alert, I'll just tell you now what we found, quickly, into collecting data is that, we weren't actually, following ACLS guidelines, 85% or greater. But we'll get into that more. Let me share just a little bit more context with you. So the 4 interventions that we're really looking at is with airway placement, confirmation, epinephrine administration, and the time to first defibrillation, and witness pulseless events. As I go through this presentation, you'll notice that I don't really talk about the witness pulseless events, and that's just because we are 100% on that the whole time that we've been doing this. So I'll be talking about the first 3 here. So just a little bit on who's included and excluded. Essentially, any non-pregnant adult admitted is included in the study. So, and then just an overview is like our strategy on and how we did this. So each PDSA cycle lasted about 2 months. Within that time, I would collect data via chart review on all the codes that happen in those 2 months. And the Get With the Guidelines has this data abstractor. And so I would enter the data in there. And then I would run the data and see how we're doing for the 2 months that I collected data for. And if we weren't meeting the requirements, I would come up with a set of differentials, present that to the code committee, which has its meeting every 2 months. And then we would, come up with an action plan and try and initiate that as soon as possible. And then the following 2 months, which would be, the start of the next PDSA cycle, we would see how did this improve our numbers. So that's kind of how this is organized. And I kind of broke things down per intervention here. So talking about the first one, so airway placement. So it's not uncommon to have cardiac arrest peri or post intubation, which is why this is an important category. So what we're looking at is that this placement is confirmed by the following here. So you'll notice it's mostly end-tidal CO2, esophageal detection devices, which I've actually never seen used, and then direct laryngoscopy. I think you'll notice that chest x-ray is not on there. That's kind of what we use mostly, but it's actually not one of the recommended modalities, and we'll talk about that a little later. But this is kind of what's required. So kind of going into differentials for why we weren't meeting our mark at the beginning for airway placement. So, and you'll notice a common theme with these is that at the top, it's kind of starts with, some documentation issues. And it wasn't that it wasn't being documented. It's just that, kind of chest x-ray was being favored more at the beginning. And, our sample size was small at the beginning too, which I think affected numbers. But, what we ended up doing, and I think it was, really, Jessica Holiday with the code committee that kind of, really helped make a new code narrator more easy to use with drop-down boxes so people could select, end-tidal CO2 or whatever modality. And that really helped improve numbers, but it didn't, totally fix the picture. And kind of what we noticed is that our DOE patients, and what I mean by that is, patients that are found unresponsive in the field and intubated prior to coming in, there's obviously, it's hard to find documentation of, what happened in the field when those ET tubes were placed originally. So that was kind of affecting our numbers. So kind of what we did about it was, we talked about the changes that were made to documentation and, the code narrator and making that easier to use. We also kind of advocated to use waveform capnography more. And so, what we found with this is that we have maybe 2 or 3 EMMAs. That's the waveform capnography device. I think one the red shirts have for sure, And then one we have in the MICU, which I think was actually lost for a period of time. And then Sydney overall was able to find it. So we started advocating for use of waveform capnography more. And with that, we were seeing some improvements, because then when you have these DOE patients come in and they code, we're able to see, end-tidal CO2 there. And this has a twofold, sort of benefit in that not only does it, confirm placement, but also it shows you how good your chest compressions are. So there's kind of two benefits for using this. Excited to show you the results for these changes. So kind of a drastic change over the months, which is pretty neat. So I'm going to kind of just relish this moment because the others aren't as good as this. So, but yeah, we're really stoked to see this improvement. So that's airway confirmation. I'm going to jump into sort of epinephrine. So this is one that, we've generally been good at doing. So epinephrine needs to be given every 3 to 5 minutes, certainly within the first, within 5-minute windows here. So sort of kind of the differentials, again, you'll notice that common theme of, documentation kind of being like the first one, I'm thinking like education has less to do with this. And what I mean by that is, it seems like people know when to give epinephrine well. But some things that have also affected our numbers with epinephrine is some sample size, which, the reason why I brought that up is, sometimes, we won't have that many codes per month, which is great. And then, sometimes at least, each month we'll have 1 or 2 codes or maybe more where ROSC is achieved within 2 minutes. And that's fantastic. We want to get ROSC as, fast as possible. But what that can do is that gets excluded and our sample size decreases. So then any errors that we do have get kind of magnified. And you can see that here with, I'll just jump to the results. In November, it kind of drops out a little bit, but otherwise, we're pretty good at, staying on our mark here and even at 100% a few times. So yeah, those were kind of like the main interventions where, we kind of already talked about the documentation, sort of cleaning that up with the code narrator and making that easier to use. And then we'll talk about debriefing kind of a little bit more with defibrillation. But yeah, and here again are the results for epinephrine. Moving on to defibrillation. So this has been our problem child. For VT, VF, these are the shockable rhythms. And, it's actually really important that they get shocked within the first 2 minutes of identification. There's not a ton of solid literature on, how to, do codes, but, one of the few things that we do know is that shocking these rhythms as fast as possible has good outcomes, and good chest compressions do as well. So this is a really important thing to get right. So in regards to, kind of, why our numbers aren't, where they should be just yet is the biggest one here. It's really documentation. And we were finding that, it was, mostly in the OR, and, we were able to talk to our representative from the OR, and it sounds like what's going on is there's essentially not enough hands in the OR at these times. These trauma patients are really sick, all hands are on deck, trying to take care of them. And, there's just not somebody really there to like, solely time keep. So it's kind of like a logistical issue. So that was really helpful, to find out that information. And then there's been some instances, and this kind of goes into like the educational side of things where, maybe pulse checks, went on to 3 minutes and they didn't get shocked fast enough, or in some cases, there's actually an equipment malfunction. I'll say I've only seen that one time. So it's, pretty rare that we've had equipment issues. In this instance, it was one with the pads just, weren't working and they had to switch them out. And then I'll jump to the rhythm and I'll talk about kind of like the last point. If you notice, it's all over the place. And then at the bottom, you'll see how small the sample size is. Another differential that I kind of mentioned on the slide before this is that with the sample size being so low, it's kind of concerning that we might be, missing our initial rhythms, and that it gets called as like PEA and not VT or VF. And you can certainly have PEA before those rhythms, but if somebody is having a cardiac arrest because they have a full obstruction of the LAD, And that's why they coded it would be weird for PEA to be the first rhythm and not the other. So it's, just kind of like raises the question as to whether or not, that's what's going on here or not. So, but to kind of summarize those points, it's honestly mostly a documentation issue. I don't think it's much of an educational issue. I think most people know, this needs to be shocked within the first 2 minutes. But there is some concern that, maybe we're, missing those first rhythms. So kind of what we're doing about this. So this is still, underway. We're still trying to work around, the best way to go about this. We might need to just find a way to get extra hands in the OR to, just to time keep. Or maybe that, starts with sort of a hospital wide code blue for the codes in the OR just to get more hands. Okay. And something else that we've talked about doing is, mock codes. We've been doing this a lot on, in the floors and the ICU, and, doing those in the OR as well, just to, get down the logistics of everything. And I brought up hot and cold debriefs because I think these are really important. And, after codes to just, the team that, just got finished with the code to talk about, hey, what went well? What did we do well? What went wrong? Because that way you can, find issues that happen during the code that maybe you weren't aware of, since they're, so chaotic. And then you can bring those up to the code committee, which is a great place to like hash things out and figure out what's going on so that, we can fix them. So the takeaways here is just kind of documentation is really important. And I wanted to emphasize that that seems like that's what's going on, and that it's not an education thing primarily. And then advocating for debriefing, because debriefing is important after codes. So, and then if there's any issues that anyone sees during codes that, need to come up, if you bring them to the code committee, that's a good way at, getting resolutions. So, all right. And then this is just, something that we may look at in the future, is sort of just kind of assessing chest compression quality. And then I just wanted to give a huge thanks to Dr. Cohen for this opportunity, and for Graceland for her work with data collection, and for our awesome code committee team that does a superb job. So does anyone have any questions?
The exclusion criteria, I saw the inclusion, and then when I looked down.
Oh, I'm sorry. So it's going to be pediatric cases. So anyone under the age of 18. I think one of the ones to comment on is if a patient's not admitted. So we'll have some codes in the ED.
I knew there was something about the ED.
Yeah. So codes that happen in the ED do count as long as they're admitted. But a lot of times the reason why the unadmitted ones aren't included is because, a lot of times these patients come in with out of hospital arrests, and, they're between cardiac arrest like every 30 minutes or, whatever. And so, and then if there's no time to even get them admitted, it doesn't really count as like an in-hospital code. And this is only with in-hospital codes. So there's just too many variables without a hospital codes.
And then did you have specific Erlanger data? I know you said we weren't meeting the 85%, but do you have a feel for how far off we are?
Oh, so like with airway, we are there. And with epinephrine, we're really there too. There's just that one dropout in November, which, as I discussed, is kind of multifactorial with our sample size dropping out. And then if you get just one or two, issues, then it goes down. But we've made huge progress in, really 3 out of the 4. It's just VT and VFib that we're really wrestling with. And again, it's really more of just a documentation thing, and, making sure we have, enough people around in the OR to do time, keeping and stuff. So that's really kind of that's our only problem child, really. Everything else is looking, much, much better. Yes.
How often are block codes done?
I might be able to speak to that more.
Did mock codes monthly, and we would rotate between the 2 critical care areas. And then last year for our annual credentialing for the acute and critical care areas, every group that came through, all the staff went through a mock code down in our simulations.
Thank you.
That's primarily nursing. nursing,
Mhm.
yes, mod code. So we really need to increase our interdisciplinary. mod
So are
codes.
they multidisciplinary residents there too?
The ones on the floors are, we do call them overhead, so it's the two that, with the first
Mhm.
one, I think, which is height residents, the weight residents.
Mhm.
multiple times a month.
Yeah.
Together, 1 year.
Yes.
So you described the hotspot, you described the hotspot both in terms of the defibrillation step, but also based on certain locations like OR setting. It seemed like a hotspot. In terms of
Yes,
what
yes.
you're. Has there been a discussion of targeting that environment for, additional training and or, troubleshooting?
Yeah, we talked to and this is all pretty new. So at the last code committee meeting, we had talked about, trying to incorporate mock codes in the OR specifically, just to help with, team building in that environment and, maybe even making specific sort of, because like these trauma patients have, their chest open, somebody's doing cardiac massage, they're needing a lot of fluid replacement, and there's so many different variables going on that we don't have in other areas of the hospital. So trying to find a way to, do mock codes that kind of favor that environment, I think would kind of help them, logistically. But it seems like a manpower thing and, a documentation issue more than anything.
Thank you.
Yeah. All right, thanks.
Oh. Great job, great presentation. And have we looked at how often we're doing these hot or cold debriefings and if that might help kind of evaluate that and kind of identify issues going forward as a way for feedback at the moment in real time?
Yeah, so that's a great question. So I don't know like how often they're going on. I might have worded that confusingly. I just kind of wanted to advocate for more. It's kind of been hit or miss for me and like the codes that I've been in when I always try and do a debrief right after, and a lot of times I'll have attendings that want to do that as well, but sometimes we don't. And I think it's an important way because like everyone has a different role in codes and not everyone sees everything. And if we don't debrief, then we might miss something that we could improve on. And so I think that's kind of where all of this starts. And as far as, we've kind of come up with the idea of, if we find out that something is not documentation related and that it was like, oh, like this was just defibrillated late or pulse check went on too long. I think as a committee, we're going to start debriefing with those teams personally, just to clarify things and to help, educationally and stuff like that. So, but yeah, I'm not sure how often the personal like debriefings has been occurring amongst the team doing the code. So yeah, thank you.
And I apologize for botching your introduction there. Yeah. We'll do better. Okay, so our next presenters represent a partnership between our GI fellowship and nursing. In fact, this was a nurse-initiated project which involved our GI fellows. So it will be Vic DiCarlo and Peter DeLu. I hope I got that right. DeLu. Okay, close. Ballpark. Okay. They're going to describe improving the understanding and implementation of Blakemore tubes in the ICU setting. Thanks, guys.
Thank you.
They've been using this to advance.
Okay, appreciate it. Good morning, everyone. I'm Vic, and this is Peter. We're part of the GI department, and so we wanted to talk to y'all about a QI project that we worked on, and to help improve understanding and implementation of the Blakemore tubes in the ICU. Just give a shout out to our mentors, Dr. Swaby for the project, part of the GI department, also Taylor in the ICU, and then the rest of the MICU leadership. I don't think we could have done this project without y'all's involvement, so we really appreciate that. Just a quick history lesson. The Blakemore tube, or the Sinstaken Blakemore tube, was first developed in 1950 by Dr. Blakemore and Dr. Sinstaken. They're actually a vascular surgeon and a neurosurgeon who developed the first prototype of this Blakemore tube around 1950. They actually published their findings in the Annals of Surgery. And this apparatus has been around and modified for several times, but this is the current model we have now. We use Blakemore tubes in situations in patients that have chronic liver disease. These patients develop compensated cirrhosis and then decompensated cirrhosis, and they can decompensate by variceal bleeding, which is what we're kind of addressing here. And so what we can do is if a patient presents with GI bleeding, so hematemesis, cough ground emesis, melena, hematochezia, and if they have suspected cirrhosis or known cirrhosis, then we must consider variceal hemorrhage. And so the gold standard for treatment of this is going to be endoscopic therapy with variceal band ligation. However, sometimes further measures are needed, and that would be a Blakemore tube. And so this is the Blakemore tube, kind of what we have here, which is the standard Blakemore tube. This Blakemore tube we placed through the mouth and then into the stomach. And then the gastric balloon, the most distal part of that smaller balloon, is inflated, and then there's traction pulled up against the GE junction. This deflates or hopefully deflates the varices and the esophagus to kind of slow or stop the bleeding. If needed, the larger balloon or the esophageal balloon can be inflated to further decrease chances of more bleeding. Just a quick tidbit of information is that the gastric balloon is volume based and the esophageal balloon is pressure based, which is kind of just a technical aspect of the Blakemore tube. We came across this problem and I think we figured out that Blakemore tube placement is used in an emergent procedure or emergent situation. It's not commonly performed. There's also certain aspects of placement that are provider dependent. This leads to certain confusion regarding the care of patients that receive Blakemore tubes. And so this has been a joint effort with the MICU leadership, the nursing, and also the GI department. I think one of the triggers was that there was an incident where a patient developed pressure ulcers on his face after a Ketris mask was maybe left in place for too long. And this kind of increased our awareness that there might be a knowledge gap on how to manage Blakemore tubes, increased our awareness that there might be documentation lapses as well. And this leads to maybe a lack of coordinated care between different different parts of the team. This is, again, a high pressure and infrequent intervention with a lot of variability. Also, when we looked at how to work a Blakemore tube, there was no like really reliable, reproducible way to measure the esophageal balloon pressure if needed. So we wanted to work on documentation and management, and I think we could improve that with a protocol and some education. So the current situation before we got started is that the nurses came to us that work in the MICU, and that they were, wanted to see if we could work on a protocol and maybe some education as well. Some things that can be variable is that whether or not a saline bag is used for traction or a Ketris mask is used for traction, whether or not an Inchi tube should be placed, and whether or not when an esophageal balloon might be inflated and when they should be deflated, and how often should nursing be checking the patient during the situation. We did the pre-survey, and 28% of MICU nurses had been involved with the management of Blakemore tube in the past 2 months prior to the beginning of our QI project. When asked on a scale of 1 to 10 how comfortable I felt with the management of Blakemore tube, the average answer was 3. And only 16% of nurses knew where the materials were to place the Blakemore tube. And I think that was more of a systems situation where we needed to address to make sure that we all felt comfortable, whether it's the provider or the nurses, what the official steps would be. So we came up with an aim statement. We wanted to specifically look into ways to improve understanding, implementation, and management of Blakemore tubes. We decided to measure our progress with surveys before and after education interventions. And this was applicable intervention as Blakemore tubes are already being used in the MICU. And this was a joint effort and decision between the GI team and the ICU staff as well. I think this is a realistic expectation because bedside teaching and education is something that is very attainable. And I think it's something we could do that was a very reproducible intervention. We started this project not too long ago in November, December this past year, and we wanted to have some good preliminary data by March. So kind of forming like a fishbone diagram, kind of looking at things that go into placement of Blakemore tube and management is that, you have a lot of different people and there's a lot of different environments that Blakemore tubes can be managed. The goal is this project is not to necessarily change the people or change the environment. That's something we can't control and might be very difficult to change as well. We wanted to look into more of a systems things where there's different methods, materials, and equipment that we could maybe protocolize to improve the reproducibility of this placement. So we developed a plan where we wanted to develop a Blakemore tube protocol with all of our partners and also looking at Elsevier best practicing for nursing. We wanted to make sure we had the materials that would allow us to have Blakemore tube placement that was reproducible. So we did acquire a posy cuff lighter, which helps us measure and inflate the esophageal balloon if it was needed. We wanted to make sure that we had a reliable way to have traction set up. And we wanted to make sure there was accessible education and instruction material in the ICU. In order to help us with that, we also developed a Blakemore kit, which can contain some of these things that we're talking about here. Also, the plan was to also have some huddle education with the nurses. And we, I think Taylor helped us get a mannequin in the ICU as well, so that we could all have hands-on experience over several weeks. So what do? We developed the Blakemore tube order set. It was actually just approved this past Thursday, and it's live in Epic now. It's an order it has several different details in it, but it instructs to have the patient intubated prior to placement with a target arousal level. There's triggers to help bring supplies of Blakemore tube kit and the Blakemore, a saline bag for traction, and to prepare for an x-ray, which is needed during the procedure. It also prompts nursing to perform vital sign checks, tube depth, balloon volume, or pressure checks. It also includes or prompts to have the provider or nurse remind us to progressively deflate the esophageal balloon if it's needed, and basically also make sure that we are taking steps to check on the patient and remove the balloon as soon or as quickly as safely as possible. So this is the Blakemore tube kit that we have set up in ICU. It does not contain the Blakemore tube itself because that's in the supply closet, but we have a pulley set up with string. We also have the posy cuff lighter, which can be used for continue to be used. The kit has instructions of what needs to be kept in the kit, and also instructions of how to place a Blakemore tube for reference, and also management tidbits to kind of help guide you if you need any reference.
Alrighty, so as Vic was saying, we basically did a pre-survey and a post-survey to kind of determine how well we were able to increase education and make the nurses feel more comfortable using these Blakemores, including the ICU staff as well. We also looked at creating this order set, which was approved, and like we said, went live last Thursday, so that's just getting started. We discussed that protocol and got that approved. We also had multiple meetings with nurses at huddles to try to incorporate as many nurses as possible. And I do think we probably reached almost everybody. And again, kind of like we mentioned before, a mannequin was left for weeks in the ICU, in an ICU bed. So people could kind of see how the Blakemore is placed, because it doesn't happen that often. Also get experiencing seeing how the gastric balloon and the esophageal balloon are blown up. Because again, this just happens infrequently. And then we did a post-education survey after kind of all our interventions were done to see how we did. And I'm happy to say that we had good success. So like Vic mentioned at the beginning, the pre-intervention survey looked at how comfortable nurses were with the management of Blakemore tubes. And as you can see, the light blue is the pre-intervention. So we asked them on a scale of 1 to 10 how comfortable they were. The average answer when added together of about 20 ICU nurses was almost 3, 2.9. And then when we looked after the survey, it was almost a 50% increase at 5.5. So if you round up to 6, but basically we almost met our goal of our primary aim of getting a 50% increase in nurses feeling more comfortable with the management of the Blakemore tube. And then with this survey, we were also able to look at some secondary aims. These included, do you know about an Epic order set? There was an order set prior to the one we created that went live Thursday, but it was very bare bones. Now it's much more robust. So like Vic was discussing, it tells people, it reminds them to check the esophageal balloon pressure every 3 hours. It reminds them if there's an issue to get a chest x-ray, to intubate the patient beforehand, to measure arousal. And so this new order set will, I think, help prevent a lot of complications, or I think give people more confidence when they're using these Blakemore tubes. But as you can see, only 10% of nurses knew about an order set for the Blakemore tube before we started. Now it's almost up to 70%. Do you know where materials are for a Blakemore tube? Which in this case, a lot of time timing is important because you're trying to get this GI bleed to stop as quickly as possible. Only about 15% of nurses answered that they knew where materials were before, and then afterwards, post-intervention, almost 70%. And then do you know about printed instructions? And so if you saw the pictures with the materials kit, there's a list of instructions on how a Blakemore is placed. Beforehand, that was a little bit higher, 30% before our intervention, and then over 80% after. So obviously really good results with kind of the interventions we performed. So briefly discussion, because I think we're running out of time here. You know, basically what we did was we had in-person education. We had a mannequin so people could spend the time themselves. And we also were able to make an order set, and all these interventions that we did have obviously shown proven results. And so this is a really good sign. Obviously, we had some barriers with timing, just getting everything done. Obviously, there's staff turnover, so we need to continue to do this QI project. And just in the Blakemore itself is something that is not frequently done. So that's something that we just need to continue to teach people about because they don't see it very often. And I think the next steps will be putting this also to the emergency room, to East, to the GI lab, and maybe doing some more simulated cases. Just want to say thank you to Taylor Casara for helping with us. You did the heavy lifting. We really appreciate it. To our mentors, thank you, GI staff and Dr. Swaby, and then to the MICU leadership as well for helping us get this done.
During the flow of this project, real actual patient events, what were some of the observations that emerged as this project rolled out, and actual patient events related to the use of the tools that you guys helped develop?
So since we've had the Blakemore tube kit, I don't know if we've actually had to use the kit, which is a good thing. And the order set just went live this past Thursday. So I think that is something we need to certainly look at more and see if that helped decrease confusion. And then maybe we can look at to see basically if it helps decrease confusion. But I think the main point of this was to help education and make sure we had all the materials appropriate so that we could readily use a Blakemore tube if needed.
Yeah, I think the cases that we saw that I know of were before this project kind of took place. And like we mentioned, there was a case where a catcher's mitt had been left on, which caused some facial trauma, which is kind of what started this project. But there are anecdotal reports of also just a lack of understanding of when the gastric balloon should be inflated, when the esophageal balloon should be inflated. So we'll have to see with upcoming cases, because I don't think we've had any yet, how everything helps.
A really good project, because things that we don't see very often but happen to be very intensive situations or where we see a lot of error. Do you have the ability or plans to roll out particularly use of the order set to other areas? I know we've had a lot of issues with Blakemores in the ED. I know that a lot of the order sets have to do with the longer term management, which one would hope would occur outside the ED, but that's not always the case.
Yes.
And other ICUs as well.
Yeah, so that's a great question. And yes, I hope that one of the younger fellows will take this project on because I think it's a wonderful one, and push it towards not just the ICU, but the emergency room. Like I said, the GI lab and then East as well. I will say that I think the next most important place for it to go is the emergency room, just because, as we briefly talked about, this is a stopgap. These can only be left in for about 24 hours. So the whole point of placing this tube is to stop an acute bleed that the patient either is too unstable for us to go in and treat endoscopically, or we tried to treat endoscopically and it was impossible due to the severity of the bleeding. We have to put the Blakemore down and then try again in 24 hours. Or sometimes there's something that we can't treat, and the hope is that the Blakemore over time will stop the bleeding and we can at some point deflate it. All that being said, because of that, there are times where people come in that are unstable in the emergency room, and the first thing that should be done is to place a Blakemore. And I don't think that the experience, or I think there's probably a knowledge gap down in the emergency room as well. So that would probably be the next step, would to be to do that. I do believe the order set is live hospital wide, so they should be able to use this order set, but they may not know that it exists yet. So that would be kind of the next step.
And I think other kind of easy places for us to implement this is in our GI lab as well, so that all of our nurses and techs and staff know about it. And also Erlanger East, where if we have someone that has become very sick with variceal bleeding, we can place a longer term or place a Blakemore tube and stabilize them to get them over to main campus, which is also something that is, I think, would be important to set up so that we can continue the care for our patients there.
And it's cost efficient to put a box in the emergency room with the materials and make sure that there's Blakemore stocked in the emergency room, which I believe there are, to make it easy for them, and printed instructions just to make things move faster. So.
Yes.
I think you did a great job of using quality tools. That's great. How often is the Blakemore tube actually used?
So I do think on the pre-survey, which I didn't put in our PowerPoint presentation, but I think when we asked, how many nurses had experienced a Blakemore placed in the past 6 months, I think, because it was just a pre-survey question, I think there was only a handful of nurses. I want to say anywhere between 2 to 4. Again, that doesn't mean that other nurses didn't take a role, that didn't answer the survey. But my guess would be, and this is just it's not based on any true documentation, is we probably only have a Blakemore placed once every 6 months, once or twice every 6 months. So it is a uncommon occurrence, because the majority of the time we get them stable enough to come to the GI lab and we place bands. So this is again an infrequent use. It's just because of that, it makes it people are uncomfortable with it because they're not used to placing it or taking care of it. I don't know if there'll necessarily be more placement. I think if we went to the emergency room and had a discussion with the emergency room, that we may see more placement, just because there may be times in the emergency room where the thought is we got to get them up to the GI lab as quickly as possible. And if those patients are unstable, maybe they would feel more comfortable placing a Blakemore. But I don't know in this case of the ICU if it would really increase the use. It may just increase the knowledge. So maybe in the emergency room.
And to kind of piggyback that, I don't think this project necessarily is to educate necessarily the ER doctor or the ICU doctor, or tell them how to place a Blakemore tube. That's not necessarily my place. It's more of I'm trying to make sure that the entire team that's involved with this project understands the materials that are needed for placement of Blakemore tube, and then how to manage it over the next 24 hours or so.
Yeah, I think that a secondary effect is that it gives probably the residents some instructions and everything to make them feel more comfortable. But the primary goal was to allow the staff to feel more comfortable with the management of it once it's been placed.
Well done, guys.
Thanks.
Thank you.
All right. Let you get in there. Okay. All right. Our next team, actually, this is a interdepartmental project involving neonatology and obstetrics and gynecology. Cassandra Hensel will be presenting today on their behalf. The title of this presentation is Optimal Cord Clamping Quality Improvement Project at Erlanger. Cassandra.
Good morning. Dr. Rains is not able to be here. He is my faculty supervisor. He is going to be joining via phone, so if I have to answer, that would be why. My name is Cassandra Hensel. I'm a second-year obstetrics and gynecology resident here at Erlanger, and I'm presenting on optimal cord clamping, which is a quality improvement project that is actually a part of the TIPQC, which is the Tennessee Initiative for Perinatology Quality Care. But I'm going to be focusing on our site. So this is our optimal cord clamping team here at Erlanger. Full disclosure, I have just recently in the past few months joined the team. Majority of the work has been done prior to me coming on. So Dr. Rains gets a lot of the credit as well as the other members of the team. All right, so problem and background. Tennessee's infant mortality rate is among the highest in the nation. The most recent data shows that we are actually 14th out of 50 states, and that equates to 7 neonatal or infant deaths per 1,000 live births. Optimal cord clamping involves waiting 60 seconds after a baby is born to clamp and cut the umbilical cord. This was traditionally known as delayed cord clamping. Oh, sorry, my chief. Well, she'll figure out where I am. Excuse me. Anyways, however, optimal cord clamping, we like this wording better because it shows this should be the goal, that 60-second mark. Optimal cord clamping is a very cost-effective way to decrease infant mortality. It really doesn't cost us anything as a hospital standpoint. So these are some of the major organizations that support optimal cord clamping. As you can see, ACOG, our governing body, is OBGYNs, as well as the American Academy of Pediatrics, the American Academy of Family Physicians, the World Health Organization, and the American College of Nurse Midwives. Specifically and significantly, the latest edition, the 8th edition of the NRP guidelines, show in that pre-birth huddle, I'm going to just make that bigger, you should be talking about, okay, what are we going to do with the umbilical cord after the baby is born? And so that's pretty significant because now we should always be thinking about that, and it's supported by the NRP. Just a brief overview of the physiology. Once the baby is born and the umbilical cord is cut, all of that blood that was previously flowing through the placenta is now going to cause an increase in systemic vascular resistance. That can cause an organ damage, excuse me. Most significantly for our neonates is going to be the baby's brain and intestines. However, after a baby's first breath, that blood flow is redirected through the lungs, and this allows the left atrium to fill with sufficiently oxygenated blood. This restores cardiac output, and then we believe this is what prevents the damage to the neonatal brain and intestines. And so there's been data that shows about 90% of babies, even 32 weeks and earlier, will breathe by 60 seconds. So the goal is that 60 seconds, but we'll get to a little bit later. We do look at about 30 seconds to kind of reassess. And so who's a candidate, or what are our contraindications or reasons why? Oh, this is Dr. Rains, so sorry. Hi, Dr. Rains, you're on speakerphone. Okay. That's okay. So contraindications to optimal cord clamping are reasons why we would not recommend it. Of course, it's going to be maternal collapse or any need for maternal resuscitation, as well as major trauma to the umbilical cord vessels, whether that be an avulsion or some sort of other trauma, as well as a complete placental abruption and uterine rupture. There are relative contraindications, and so those will be hydrops fetalis, recipient twin in TTS, and other selective lethal congenital malformations. And one everyone always kind of wonders, and things that have changed since we've now started recommending is general anesthesia is no longer a contraindication to optimal cord clamping. And so therefore, this is significant because if we have a mom that we have to take back, she doesn't have an epidural, she doesn't have good pain control, the baby's heart rate is down, she needs to have her baby delivered. Now we can do that. Mom's put under general, baby's delivered. We can still wait that 30 seconds, reassess, hopefully get to that 60 seconds of optimal cord clamping without worrying about general anesthesia. So why is this important? We've broken this down like we do in everything for neonatology and obstetrics by gestational age. So our term babies, or those born after or at 37 weeks and 0 days, we've shown a higher iron store in their at 6 months of age. This equates with a decreased anemia and has shown improved developmental outcomes. What we like to focus on, or pretty significantly, is our preterm babies, or those that are born less than 37 weeks. We've shown an improved overall survival. And so since Tennessee is in that category where we have the highest mortality rate, just doing this and increasing it potentially should decrease our mortality rate and improve our baby's survivals. Otherwise, you also see a better stabilization of the baby's blood pressure, and therefore need less pressure support with fluid boluses and pressors in that first 72 hours. We've also seen a reduced rate of intraventricular hemorrhage, as well as a decrease in necrotizing enterocolitis. And also you see the same benefits that you see in the term babies, which is increased iron stores and decreased anemia, and that follows then the decreased need for transfusions. So how important is optimal cord clamping? Well, it's pretty important. In those preterm infants, or those born before 37 weeks, we can see by just waiting 60 seconds to clamp the cord, you can decrease that death rate by about 33%. So the number needed to treat, or the number of optimal cord clamping that needs to be performed to save one baby's life, is about 40. And that's in preterm babies. And then even more significantly, for our preterm babies that are also very low birth weight, or less than 1,500 grams, that number needed to treat is only 20. So without causing any increase in hospital costs, we would be improving our patient outcomes. And all of this data comes from a large Cochrane review of over 2,000 preterm babies. So quality improvement, our aim statement. We sought out to increase the percentage of all neonates born at Erlanger that had their umbilical cord clamped at least 60 seconds or more after birth to 90% between this time period of March 2022 and 2023. Talking about the different aspects, our outcome measures, we looked at the number of neonates who received their cord clamped at least 60 seconds after birth. We also included an additional tracking for mother's race, ethnicity. We were interested to see if there were any disparities, which we'll talk about later. Our process measures, so we did data capturing, we've tracked and reported that on a monthly basis, as well as a quarterly basis. This red cap part kind of deals with the larger TIP QC optimal cord clamping. So we are one of 9 sites. And so that's what that's referring to. Our balancing measures, or how we want to make sure we didn't have any unintended consequences. We looked at the number of neonates with hypothermia or first body temperature less than 97.7 degrees Fahrenheit, as well as APGAR scores at 5 minutes less than or equal to 3. So how do we do this? This is a timeline of all of the changes that we've made to hopefully, or how we tried to increase optimal cord clamping. So this started in March with educating our obstetric providers, as well as the neonatologists. We included the neonatal nurse practitioners in that education. We also educated the obstetric residents, which is how I found out about the project. We also included other stakeholders, including the nurses, the respiratory therapists, and that was an educational email. We've had staff meetings in May of 2022. And then in June, we started integrating a 60-second kind of area where you could chart in Epic and say, was optimal cord clamping completed? And then in mid-July, we had a hard stop. So now whoever is filling out that delivery summary will need to comment, okay, was optimal cord clamping completed? How long was it done for? And that's given in seconds usually. We just continued educating other stakeholders, including the neonatal transport teams, as well as we got the parents involved by educating them, and there are posters in their rooms. So this is a busier slide, but overall, this is the key driver diagram. This is actually for the entire TIP-QC optimal cord clamping project with all those 9 sites, but I've highlighted here things that were significant for our outcomes here at Erlanger. So as we talked about, our goal was to increase the rate of optimal cord clamping to 90% by March of 2023. We talked about all of the education, all these stakeholders here and here. We also have a flow chart, which I'll show you in just a second, that's in every delivery room. We've integrated to the EMR, and we've conducted case reviews. So if there's a baby, say it says they did not get their cord clamped at 60 seconds, but the APGARs are 8 and 9, we've opened those charts and we're looking, okay, so they probably did get it. Maybe we just click that button at like 56 seconds or something like that. So this is a example of the Erlanger flow chart that's available in all delivery rooms. I'll just briefly run through it. Pre-birth huddle, like we talked about and mentioned in the NRP. Are there any contraindications? No. Okay, so we wait that 30 seconds. And this is where communication between the obstetrics and neonatal providers is key, because the obstetrician, whoever is delivering the baby, will be trying the baby, gently stimulating, will be just talking back and forth. Usually in the operating room, the neonatologist or whoever is on that team is like, okay, baby's looking good, just keep stimming, you're doing good. The timer is running. We have that available in all rooms. And then we just continue to stim the baby, and then hopefully we get to that 60 seconds. And then we've already talked about these benefits and the contraindications and relative contraindications. So our results. So overall, our baseline rate of optimal cord clamping back from January of 2022 is 74%. And our goal, as we talked about before, is 90%. And so what you've seen in this graph is this is our total, this is the percent, here's our goal. And overall, as we've gone through the project, we've increased. We still have some work to do, but we have consistently gotten that optimal cord clamping to be over 84%, which is pretty significant. There is some data that shows if you increase a hospital's rate of optimal cord clamping by 10%, that decreases infant mortality rates by 5%. So briefly, just to talk about that extra data that we gathered based on race and ethnicities, we do see a disparity here between our non-Hispanic white, our non-Hispanic Black, and our Hispanic moms. But what is important to note is majority of our patients, so say we have about 500 babies delivered per month, majority of those are non-Hispanic white, whereas you'd get maybe 50 or 40 in each of these other categories. And so if you don't get one of these babies to have their cord clamp, it can drop that percentage significantly. There's also some charting that we need to make sure is correct, that 58 seconds we were talking about, or those specific case studies. So that's some future work that we'll discuss shortly. Our balancing measures, we were well below. Our APGAR score is less than 3, so that's good. We've still got some work to do on hypothermia, but that'll be a future project. Okay, so discussion. So optimal cord clamping has strengthened communication between neonatal and obstetric providers. By educating all stakeholders and implementing the documentation in the EMR, we have increased to that overall average of 84% from our baseline of 74. We will continue these methods to achieve our goal of 90%, hopefully, at Erlanger. And then we can extrapolate from that by continuing to increase optimal cord clamping. We hope to improve mortality rates for infants born at Erlanger, especially those preterm neonates. Future works briefly. We have a goal to achieve 90%. We discussed that earlier. We'll continue to incorporate education. We want to work on that hypothermia. We want to figure out if there is truly a racial disparity, or if we need to figure out how we're evaluating for that. Additionally, this is a part of the TIP-QC bundle for potentially better practices. And then I'd like to thank Dr. Rains for allowing me to be on this project and for all the work he and his team has done. I'd like to thank Dr. Bennett for answering all my QI questions. Sorry, I don't know if they were all, pretty intelligent, but I appreciate you being gracious with me. And then all neonatal and obstetric staff at Erlanger and the TIP-QC team. Here's my contact information, as well as Dr. Rains. If there's any questions that I don't happen to get to that you have, or any further information you'd like about the optimal cord clamping project or the TIP QC, you can reach out to one of us. But otherwise, does anyone have any questions for myself, or Dr. Rains is on as well?
What, and if you said this, I apologize if I missed it, the barriers that you encountered?
I don't know if I specifically mentioned it. It's kind of here. But it's, well, I mentioned it, but it's not specifically written in my PowerPoint. We did see barriers, and that is getting staff educated on the importance of documenting in the electronic medical record of how long we waited till that cord was clamped. We had to make sure that all stakeholders were educated on the importance of this. And so they were thinking about it when the baby was born or in that pre-birth huddle. We also had some barriers in those it's essentially a charting barrier really that we have right now. And so that's why we did those specific case reviews. And so that's probably where most of our future work will be.
So in a real world event, I could imagine, you know, there's some adrenaline flowing, there's a lot of, obviously, this is a big event in their family's life, and then depending on the experience level of the team in the room, it can be a big event for them as well. Are there other reminders that are real time that are used as a kind of a safeguard against prematurely clamping that cord in the cases where that's safe?
Yes, there are. And some of these reminders are essentially in the operating room. For every C-section, our NICU team comes to those deliveries. There's some data that shows between vaginal and C-section deliveries, you're less likely to get that 60 seconds of cord clamping in a cesarean delivery versus a vaginal. And so at every C-section they come, and it's kind of just communication. So those are our barriers. So usually we're drying the baby, we're looking at NICU, they're saying, okay, baby's looking good. Okay, wait, we're at the 30 seconds. Let's wait. Okay, we've got good tone. We're breathing. Okay, go ahead. And then they'll say, okay, you're at 60 seconds now. And then we clamp and cut the cord. In a vaginal delivery, that's probably some area where we could do a little better. I was actually talking to Dr. Rains about this. We do have timers in the delivery room for that cord clamping. However, we really go by the fetal heart tracing. And so if the nurse or whoever is in the room is not looking at when that baby was exactly born, we look to see when the heart rate dropped off the monitor, and then we go 60 seconds from there. But we were, Dr. Rains and I were discussing briefly how incorporating maybe another timer or like another reminder in the Epic system, like don't forget about the cord clamping. So good question.
This being part of a big, like a multi-system project, multi-center project, what are some of the advantages and maybe disadvantages of that kind of a QI project?
Okay, this might be a question for you, Dr. Rains. So Dr. Bennett asked, as this is a part of a larger QI project or the TIP QC for the state, he was asking the advantages and disadvantages of that type of project.
Hello. Hey, Dr. Bennett. Great question. As you guys probably know, the TIP QC is part of the Tennessee, we're doing the Tennessee's Tiniest Babies, and we're targeting mostly the infants born at 29.6 weeks or less that are admitted to level 3 and level 4 NICU. So this optimal cord clamping project is part of our basically bundle 1. Now there's 4 big bundles, and one of the great advantages to this project is that it coincides nicely to the neuroprotection bundle. So we're trying to, as a state, decrease the severe IVH, defined as grade 3 or 4 IVH. And this optimal cord clamping is part of that, potentially better practices, or PDP is what we call them. So this coincides with bundle 1, and there's going to roll out, well, bundle 1 is rolling out soon. And bundle 2 is respiratory, like the chronic lung disease. Bundle 3 is GI or neck, and bundle 4 is infection. So this optimal cord clamping project was a great pilot study for us to get that rolling to coincide with the severe IVH decrease. And did you ask about disadvantages too, or
Yes,
what
he
was the
did.
second part?
Yes, he did.
Yeah. So they're really, this was a really low hanging fruit in regards to money and effort and time. I think the biggest disadvantage was just it was a bit hard to try to get everybody on the same page, but I think, cost wise and everything, this is just the greatest bang for your buck. Just waiting an extra 30 seconds or so, and to decrease the mortality and to decrease severe IVH and all these sort of things. So there were not many disadvantages, interestingly, up to this endeavor.
All right. Thank you very much.
Thank you.
Good job.
Thank you, Dr. Raines.
All right. With reps, I feel like we're getting into a groove now. This is good.
No, no.
Okay. So our fifth platform presentation today is from the Department of Pediatrics. Doctors Nikita Patel and Keelan Passmore will present on improving water safety knowledge and discussions in general pediatrics clinic.
You can do it here, but most people can use them. Okay. Just be sure that if you're speaking, you're about that far. Okay. Because it won't pick up if one of you's not. Okay. So when you turn your hand. Gotcha. It's not going to pick you up. It's when it's there.
Okay, thank you. All right, well, good morning, everyone. Like Dr. Brenna said, I'm Nikita. This is Keelan. I'm one of the third-year pediatric residents, and Keelan's one of our second years. So we're going to be presenting improving water safety knowledge and discussions in our general pediatrics clinic. Special thank you and shout out to our mentors, Dr. Robin Balzer and Dr. Vanessa Pig, who are some of our great general pediatricians out in our clinic and helping us with our project. All right, so why does water safety matter? Drownings represent one of the leading causes of unintentional injury related to death in children of all ages. Specifically in Tennessee, data from the 2022 Child Fatality Annual Report of Tennessee revealed that the death rate from drownings in Tennessee has recently been at or higher than the national average. And that's shown here by this figure. Personally, we've been involved in the care of multiple children who have suffered from often preventable submersion events. This project was actually inspired by a couple of patients that I had taken care of in the PICU prior to creation of this project, who just had I think I had like 4 in a row who had injuries related to submersion event. And of those, at least 2 or 3 of them felt like they were preventable injuries. And so this really got me thinking as to how can we prevent some of this from occurring in the future. And so that was the kind of inspiration for the creation of this project. And just going with that, as future pediatricians, we realize how important it is to improve our knowledge base and about water safety and discuss these principles with our families at their well child checks. So the current situation, general conversation amongst pediatric residents revealed that water safety was not being discussed during well child visits for a variety of reasons that we'll get into. Furthermore, there were no formal educational materials regarding water safety anticipatory guidance. Anyone who's been in our Gen Peds clinic knows that there's multiple handouts that we have that are very educational, that deal with a lot of different topics, and water safety was just not one of them. And then initial resident and patient surveys show the following: 50% of residents, only 50% of residents knew basic water safety principles. That included things like, when are you supposed to have a fence around your pool? Or, when should you start talking about water safety? At what age? Where is the local swim classes and CPR classes? Things like that. 47% of residents discussed any water safety principles with families, And 12% of residents, only 12% of residents documented any discussions of these principles within their within their well child note. So our aim statement, within 6 months of initiation, we aim to improve the resident competency of water safety and the rate of these discussions between residents and families during well child checks by 50%. So this is just the fishbone diagram kind of detailing the things that we wanted to talk about or look into as components that lead to maybe potential barriers to discussing water safety. Some of the things we can't change, like people, those people are the residents and the attendings within our general pediatric clinic. Some things that we could look into were things like the equipment and process. So lack of resource, there was no, like I mentioned earlier, formal educational materials related to any water safety, including some kind of alteration to our note template. Excuse me, and the environment, you know, our well child check times are scheduled for only 20-minute slots. Where can you discuss this within that time? Some social determinants of health, things like transportation issues, financial insecurity, all of those kinds of things could be a barrier to even discussing this with families. Management, is this a low priority issue? Do residents perceive water safety as low priority compared to all the other things that we have to talk about? And then process, you know, is there a lack of knowledge and low confidence in water safety in general to be able to discuss this? So these are some of the measures that we looked at. The outcome measures were primarily resident knowledge, the rate of discussions, and the rate of documentation of these discussions. And those things were evaluated by various patient and resident surveys. The process measures were the number of residents that utilized handouts, and then which we'll get to, and the number of residents that documented these discussions within EPIC. Some balancing measures or reasons, potential reasons why these discussions were not had, things like lack of time, the availability of certain handouts, or for example, like an inappropriate season where a discussion is not had during the winter, but only in the summer.
Yeah, so to get into our first PDSA cycle, basically we conducted our PDSA cycles over the span of 4 weeks, just because the way our clinic is structured, the residents rotate. We get a new group of residents every week. And so by 4 weeks, we kind of have all the residents rotate through clinic. And so we started over last summer and then basically had our project go up until this past November, December or so. And so each PDSA cycle took about 4 weeks to conduct. For our first one, we planned on educating the residents on water safety principles. And we really wanted to help facilitate the discussions with families about water safety during the well child checks. And to do this, like Nikita was alluding to, our main intervention was to create a water safety handout that we could use that not only included facts about how to be safe around water, but also included resources for local swimming lessons and CPR training that families could utilize here in Chattanooga. The way we studied our outcomes was by using resident and post-encounter surveys for our families. And so in each instance, we noted that residents had improved knowledge of water safety after utilizing our handouts, and that we also had increased rates of discussion, as you'll kind of see later on in the PowerPoint. And so when we looked at that, we saw that our handouts are working. So they've continued to be available for residents up to this point that they can take into the well child checks to talk with families about water safety. And we're really working on improving the accessibility of these handouts, making sure they're always available for our residents in clinic. And then leading into our second PDSA cycle, we really wanted to focus on improving the documentation of water safety. But this is one of the examples of one of our handouts that we created. They're age appropriate, so this one was focused more on newborns, infants, and toddlers. And as you can see, there's facts about drownings, which Dr. Patil had kind of gone over already, ways to prevent drownings. And a lot of this information was taken directly from the AAP and a lot of these figures. And like you see there, there's resources for CPR, certification, and swimming lessons. Here's our handout for kind of the younger children and teenage population.
Just to note, these are available in both English and Spanish. We have a huge Spanish population or Spanish speaking population in our Gen Peds clinic. So we wanted to make sure that we have those available for both languages.
That's a good point. Thank you. And so for our first PDSA cycle, when we did post-encounter family surveys, both before and after we implemented this handout, before, families marked that residents discussed water safety about 47% of the time, whereas after we had this handout, this increased to 76% of the time. And from our resident surveys, as Nikita had mentioned, about 50% of residents demonstrated that they understood the basic principles of water safety, but 87.5% of them marked that they had increased understanding when we did the post-resident surveys. And so for our second PDSA cycle, we really wanted to focus on increasing the documentation of these water safety discussions. And so to do this, we actually altered our EPIC note templates to include a section at the end, yes or no, did you talk about water safety with your family? And again, we utilized our resident surveys to study how big of an effect this had. And so we found that documentation increased from 12% all the way up to 88%. And so we've basically kept this EPIC note changed, this template changed to our documentation. And so it's still part of like all the well-child templates that we're using to date. And as kind of a future PDSA cycle, we're working on potentially including our water safety handouts or facts about water safety into the after visit summaries that we can have available for families. This is just kind of showing in graph form what I had mentioned. Our documentation rates increased from 12% to 87.5%. And so taking a step back and just looking at our two PDSA cycles, it seems like our handouts really worked and helped accomplish our goal, even though it wasn't quite up to what we had set out for our aim statement initially. But the residents demonstrated they had increased knowledge about water safety. We increased the rate of these discussions, which was kind of our primary goal. And we've also secondarily kind of improved the documentation of these discussions by altering the EPIC templates. And so there still exists some barriers that we've noticed, like Nikita was mentioning, timing's the big thing. We have a lot of anticipatory guidance we need to talk about during these pediatric visits. And so sometimes water safety just kind of takes the back seat to some of the other things we need to go over. Like I mentioned, we're working on making sure these handouts are always available to our residents and kind of trying to troubleshoot the best place to put them in our clinic. Something interesting that we noted during the study was as we started in the summer and then we kind of progressed to the colder months, our residents discussing water safety less frequently during the colder months, just by virtue of not perceiving that families are actually using pools out in the colder months. And so that's something we could potentially look into for future PDSA cycles. And then, like Nikita had mentioned earlier, do residents still perceive this as a lower priority issue, just given all the other kind of socioeconomic factors that our families have for our specific patient population in our clinic? So next steps, we would like to create a actual formal lesson plan that we can use to educate residents about water safety versus just having the residents overlook the handouts we created, especially as our new interns come in over the summer. I think that would be really important to try to educate them on our initiative. Like I mentioned, we're working on creating a way to put our handouts into the after visit summaries. And then something that I didn't include in this PowerPoint, but part of the data we collected from our encounter surveys was how many families are actually CPR certified, how many children are actually engaged in swimming lessons. And so when we did that, we found that 35% of families reported they had a caregiver that was CPR certified, and only 22% of them had children that had received swimming lessons. So there's definitely areas that we feel like could improve and potential target areas for future studies. That is all we have. We're happy to answer any questions anybody may have. Comments about our clip art that we
rolling out things like this, it sounds like it's some fairly
straightforward tools and methods to accomplish the goal. Did you get any feedback from families regarding those tools and how effective they are in helping them have that understanding of what the water safety goals?
I think in general, we had a pretty positive response to the handouts. As you can see, they're pretty to look at. And then having the graphics too, I think is really helpful. Because even if there's a lot of words, at least you can see some of these things. And I think the most positive response or the things just like anecdotally that I was hearing from parents as I was giving them this handout is the resources for CPR certification and the swim lessons. Because many people will say like, yeah, I know I'm supposed to do that, but how or where? And so having those resources available within the area of Chattanooga, I think was really what we got the most positive response to.
Did you get any feedback regarding cost? So I wonder if some families can't really afford to send their children to swim lessons or to receive a CPR certification because that is pretty pricey.
For sure. And that's something that we, discussed that we could potentially look at in the future as future PDSA cycles to look at the socioeconomic barriers that lead to, maybe why parents or families don't participate in these resources that are available.
Hardest things to do with the quality improvement project is to maintain it afterwards. So you're going to continue to teach this to the residents and incorporate it into their education?
Yeah, so in our Gen Peds clinic, every month we have like a handout of the month. So I think this could definitely be incorporated into that cycle, especially during the summer months. And then the Epic Note template alteration will remain as part of our well child checks going forward.
And will you be able to look at results of how often that is checked off in Epic and look at the data?
Yeah, we could potentially look into actual patient charge. That's not something we had set out to do initially with our just with these first couple PDSA cycles, but I think that's definitely easy enough. We can always look at what well child checks everybody had on their schedule for that day and just go into the note and it's a simple yes or no. So it'd be something that'd be really easy to look into.
Thanks, guys.
Thank you.
Good job. Okay, our last speaker this morning, Tammy's going to come down and tee it up. Thank you, Tammy. So our last speakers this morning represent infection prevention, and our speaker today is it Tamara or Tamara? Renee. Hi, Renee. All right. So Grayson Eubanks, and we have two presenters. Wonderful. Okay. Oh, moral support. Wonderful. Well, and the presentation this morning is improving patient safety by decreasing CAUTIs and IUC utilization rates. Welcome.
Thank you. Good morning, everyone. So really, we're here to represent the CAUTI committee. So Taylor Casaro could actually be up here with us. We began our project in 2022, I would say probably around February, but we officially didn't start until April. Just a little background, everyone knows that HAIs compromise patient safety. CDC states that urinary tract infections are the most common healthcare associated infections reported to the National Healthcare Safety Network. And we are required by CMS in the state to report to NHSN. NHSN has a standardized infection rate, which is basically a summary measure to track HAIs over a period of time. The goal is to be 1.0. Anything above that is not good. Anything below is great. But there is also Health and Human Services Department that has a goal of 0.7, which is what we want to obtain, if not lower. And then they also have NHSN, the standardized utilization rate, basically how often we use Foley catheters and how long they're in place. So our current situation is we noticed that BEH campus had an SIR of 1.4, which means that we're doing pretty much like 40% worse than the rest of the nation in calendar year 2021. So of course, that's not good. We went back, looked at the data. We saw that these units here, MICU, North Wing 8, North Wing 9 South, neurotrauma, CV, and 3000 had the highest rates. So we wanted to make sure we focused on those areas. And then we also had our CAUTI committee that was in place. And though we had a physician champion, Dr. Sizemore, we were performing ACAs, apparent cause analysis. We still saw that we had some missing pieces in our group. Some of our limitations were participation, specifically from our providers. And then some of our interventions that we came up with as a group, we weren't able to implement. So during our ACAs, these were some of the leading problems that we saw that contributed to our high CAUTI rate. The nurse-driven protocol indications were not always appropriate. We had inappropriate ordering of UA reflex to cultures by some of the residents. We had a lot of pan culturing. There was convenience of indwelling urinary catheters being used by our clinical staff. Our CAUTI bundle was not always documented. Pericare was not always documented. And sometimes we would come across during our ACAs, there was actually not even an order for the Foley catheter after 48 hours. So the order would have to be renewed every 2 days, every 48 hours. And sometimes the catheter would be in for additional 3 or 4 days before anyone noticed it. And by that time, it was too late because now we have a CAUTI. So some of our process changes was basically to our CAUTI committee restructure. We had an executive sponsor, one administration ago. The CEO brought it to everyone's attention that we need to really focus on it. And I don't know if a lot of you remember, but a couple years back, we actually had a hack penalty of $1.4 million related to our CAUTI rate. We also got some urology involvement. We got Dr. Singh and his team. Of course, Dr. Sizemore, infection prevention medical director, was involved. And then we also had data analytics and leadership. And when I say leadership, I'm talking about the entire C-suite. It was great. We saw them for about 3 or 4 meetings. So we greatly appreciated that. And then of course, nursing leadership. We revised our charter, and that's just a little snapshot of our charter. As you see behind the second page, there's a little shot of our heat map. And then also we used a key driver diagram and a PDSA cycle. So from our key driver diagram, this was at the beginning of the project. So everything that's yellow is what was in progress. Everything green was a go, and everything red has not started yet. Our aim was our CAUTI incidence will be maintained at 0 for calendar year 2022, but our global aim was reducing incidence of hospital-acquired infection throughout the entire system, even though we were focusing on BH campus. And our key drivers, as you see, are there: rounding, nurse-driven protocol, urinary retention management, CAUTI ACAs, and our culture management. But one PDSA that we did do, because the big focus for us as a CAUTI committee was rounding, being present, letting staff see that we were there to answer any questions. So we had, oh, I'm sorry, I jumped. Let me go back. This is our current one, our current key driver diagram. And I had to show this one because you see all that green and before it was a lot of red. So we were really proud of that because this is ongoing. So as you see, we've made some great strides with reducing our CAUTI rates. However, we still have some work to do. And those 3 that are in red are physician driven. So for our PDSA, we had 1. We were still working on 2. I want everyone to remember that our CAUTI committee is ongoing and each and every one of you was invited. For our plan, the IP and infection prevention and nursing leadership, we began doing rounds on indwelling urinary catheters. We started that back in April to our high incidence of CAUTI units and floor. And throughout that time, we did it for about 8 weeks. We had the opportunity to talk to the nurses, see what some of their issues were with why they were keeping Foley catheters in. And as time went on, we ended up using the RASCI. We used our data analytics team, and they were able to help us with the information that we had so we can gear more education toward what the staff needed. IP completed a compliance graph, and we did find that acute urinary retention was the most commonly used indication from the nurse-driven protocol. And then we reviewed it in June of 22, and nurse leadership decided that we need to maintain the rounding. And so we started PDSA cycle 2. So some of our PDSA outcomes, we had that unit level rounding tool that had already been developed, but we were able to go back and revise it. There was a lot of education opportunities, because one big education opportunity that we found was that the nurses had the bladder scan policy process. However, they didn't know what to do after they straight cast twice, and then they put the Foley in, but what do you do from there? So we were able to go and get some tools revised for that. Discontinuation of indwelling urinary catheters in EPIC. Used to be a 3-step process. We were able to get it down to a 1-step. I told you about the bladder scanner protocol revision. We had a point prevalence study. BARD came in and did that study for us. We were able to, just MICU, correct? We were able to do a trial of the Primo Fit, but of course, as everyone knows, there was a lack of suction availability, so we halted that implementation, and then we updated our ACA form. So these are just some of the tools. We went back and revised here where we were looking at the CAUTI bundle to make sure that all interventions for the CAUTI bundle were present. This is just a picture of our a snapshot in EPIC of the one place that the one step for discontinuing a Foley catheter. As I said before, it used to be 3. And our bladder scanner policy used to end right here where my arrow is pointing. So everything below here, we were able to develop with Dr. Singh and Dr. Sizemore. So now the nurses have guidance on how, when they place a Foley catheter, of how long that Foley catheter is supposed to be in. In addition to that, Dr. Singh also expedited when the patient is being discharged and they're going home with a Foley catheter, that they would have 3 to 5 days after discharge to get to the urologist, and it used to be 2 to 3 weeks. So that was a great improvement. This is just showing some of our outcome data. As I said, in calendar year 2021, we had about 29 CAUTIs, and we got that down to 10. And as you see, if you look down here, we actually went from a 1.4 in 2021 SIR to a 0.47. So we've done really great with that. This is just showing that even though we decreased our CAUTIs, we did not decrease our utilization rate. It remained the same. So some of the barriers that we had is just education for providers. There may be a platform now, but I think that back then we didn't have a platform. So if we did have an intervention change or we wanted a process change, we could get it out to nursing staff, but we also needed support of the physicians and providers, and we weren't able to get that out in a systematic way. I had the opportunity of speaking to the hospitalists. I spoke to the internal medicine residents, but just being able to get that education out to everyone, we found that was a barrier. Also, we have EPIC report for second sign UA. Before we started our restructure of the CAUTI committee, we actually had a UA to reflux process that went into place for residents, that when the UA reflex culture was ordered, then they have to have a cosign from the attending. And then our protocol for appropriate urine culture, which is some education we need to get out to our providers. Some of our lessons learned is that staff enjoy seeing leadership. That was a big one. They like to see us around. They like to ask us questions. They were just interested that we were interested in their work. And then we had better buy-in from providers when they were educated on the changes, when I had the opportunity to speak to the hospitalists and the internal medicine residents and explain to them how we get CAUTIs and go through that NHSN process. Then I had better buy-in from them as far as not having catheters in so long, or if it's not clinically indicated, having that catheter removed. And then our frontline staff are involved in our CAUTI committee. So next steps, we will continue infection prevention to do surveillance. Our clinical staff leader training that we have coming this month is going to include some indwelling urethral catheter rounding on the floors and units in their education. We need a universal platform for provider education, and then multidisciplinary rounding for line assessments. And we're also going to work on an EPIC report for compliance with our acute urinary retention management protocol, because we want to see that if we do have patients that have to have a Foley catheter for acute urinary retention, that it is coming out within a short period of time. And then we'd like to thank Dr. Adam Campbell, who assisted us greatly with the restructuring of our new committee, all of the nurse managers, clinical educators, bedside nurses on selected units, and our executive leadership. And just thank everyone for all the hard work and what this has done for our campus here at BEH. That's it. Any questions?
I have a question about, okay, so we significantly dropped the CAUTI rates, but you said, we didn't see a decline in utilization. So what kind of steps do we need to take as far as addressing the utilization piece of it?
I think one of the biggest steps is just looking at when we do order a Foley catheter, when providers order them, is it really necessary? There's other ways to monitor strict I's and O's. Sometimes we have patients come in, they have chronic urinary catheters. Is it necessary? Sometimes if a doctor orders something, if a provider orders something, sometimes they go home or they go to their next facility and it's in there, so people feel like it needs to stay. But the whole goal for us to decrease our utilization is not to put them in if it's not absolutely necessary. All right, thank you.
Don't touch it. She says, don't touch it. All right.
I'm gonna pull the.
All right.
So they can see this. There we go.
All right. Well, what'd y'all think? It's hard to hold anybody's attention for a couple of hours, but I think our speakers did a great job of holding our attention, giving us some really interesting approaches and good use of QI tools, methods, teaming. I saw good examples of teaming within and across departments. That's a really exciting feature that's emerging now. And I also got the sense of just how proud everybody was of the work they'd accomplished, you know, and the things the ideas that they still have to continue to improve. And this really is the lifeblood of an organization. It's not just the daily work. It's truly creating better ways of doing this important work with our patients always front of mind. So what a great morning. Appreciate everybody being here to celebrate this. We are a learning organization, and part of that is our little committee, our tiny little committee that's behind this is trying to learn as well. And that's where that QR code comes in. So kindly give us your feedback on what you've experienced so far. Is the environment, but also the quality of the speakers and other factors. We're going to continue to improve with your input. So thank you for the feedback that you give us. We are a little bit ahead of schedule, which means our esteemed panel of judges has a little bit more time than we'd previously predicted to put their heads together. Yes, we are going to select a best of this 6 platforms, but that's not meant to be any kind of a downside for anybody else. We want to highlight characteristics of QI work because really this is about learning and improving. And so one of the opportunities we have is to select one of these that sort of shows us in the best possible way what this work looks like, both in terms of conception, it's how it's carried out, and then the impact it has on our organization. So without further ado, we will let our judges panel begin their deliberations. For those of you who have posters that need to be set up, I think everything is staged outside in the hallway. You can grab your posters, get an easel if you didn't bring one from your departments, and we can start setting that up in the medical mall. Tammy's going to help us orchestrate that. Are there any other announcements that I may have overlooked or forgotten? We will be having our announcement of the best platform presentation at 11:30, and that will kick off our opportunity to go and enjoy the poster session. For those of you who want to go ahead and take this opportunity to do some photos of your teams with your department members, go ahead and take advantage of this little bit of time while our judges get started, and then we'll get rolling on to the next steps. Thank you. All right, folks. Well, I'm really excited to hear what we're about to announce. Just as a reminder, once we are finished with announcing the best presentation from this morning, we do have our poster session up in the medical mall. So it's an opportunity to look at an additional 18 projects that occurred or are occurring. Some of them are ongoing projects as well. So lots to see, lots to learn. So please make your way up there and spend a little bit of time with those teams. They really deserve that attention and support. And I know they want to tell their stories. Okay, so without further ado, I'm going to invite Jill Stillman to the podium here to give some comments about what was seen this morning, and then we will have our announcement.
All right, thank you. This is actually my second year to be involved with our QIPS Day, and wow, what a difference a year makes even. It was fabulous last year, but we can definitely just see another level this year. And so congratulations to all of the entries. I did just want to say we definitely love the collaboration, the interdisciplinary collaboration. We love seeing the tools that were used. And it was very difficult. We took the entire, well, we were supposed to have maybe 30 minutes, but we took even longer.
Oh, we were very liberal with how much we discussed.
There you go. So lots of discussion. So thanks to everybody, and just keep up the good work, because to me as a nurse, I feel like we're doing this every day, but to stop and take time to document it and to really think through the process and to share those successes. We were talking about the time that we spend doing, root cause analysis and looking at events compared to the time that we spend looking at these successes and the improvement that we're seeing. I just think it's really encouraging. I love the interdisciplinary part of it. And I just love the focus on the quality improvement. So thank you all for doing that. And it's so interesting to hear these. And it was, I know we always say this, it was a very tough decision, but it really was, because there were great strengths in all of the presentations. And so thank you for your work in doing that for our patients and for the growth and development, I think, of our staff. I'm very encouraged, and thank you for that.
All right. Thank you, Jill. Great words. I do want to thank Jill. I want to thank Melissa. I want to thank Greg for being very willing participants and great judges. Great discussion over the past hour, as Jill really detailed. Thanks to Dr. Bennett as well for his great work and Tammy for putting on this great day. And thank you to leadership. I want to thank Mr. Coleman and Dean Haynes again for their support from the college and from the hospital system as a whole. So thank you. So it was a tough decision. But without further ado, the winner this year is improving understanding and implementation of Blakemore tube in the ICU. Dr. Carlin DeLu and Taylor Crisaro. Thank you very much. Very good. Do they have representatives here? Come on down. What are you doing in the back row? You're a winner. Come on. Great job. Everybody did a great job. We want to thank everybody.
Good job. Thank you. Thank you. Great work. Thank you very much. Great work. Yeah, you go ahead. Steve.
Take your time.
Yeah.
Yeah. Vital aspect here.
You guys are the center of attention, so find the center. All right. All right.
Yeah, we'll see. Can we kill that, John?
John?
Yeah. He's the man.
All right.
Close and personal. Ready? Great, thank you.
All right. Thank you very much.
Congratulations.
Thank you so much.
It's great having all y'all here.
Yeah, thank you very much. All right, enjoy the.
Yeah, let's do some photos.
Yeah. I've still got your contacts. I'll send it to you.
Yeah.
Great shoe,
All
thank you.
Great work.
Oh, yeah, was there a runner-up?
There was.
Oh, no. I'm gonna leave before the ring.
You guys need some spirits in here.